Well, hello and good afternoon, and thank you for joining us for this symposium of the Manchester Medical Society on delivering sustainable healthcare. I'm glad that so many of you have been able to join us to discuss this very important topic. It's a very wet and rainy day here in Manchester, but you're all very, very welcome. There's been some slight changes to the program, which we've had to make at the last minute, but I'll let you know about those shortly. So just want to tell you about how the symposium is going to work. We've got an exciting lineup of speakers for you this afternoon. We're looking forwards to receiving your questions. And we want you to use the Q&A function on Zoom, and please do put your questions and we'll look at those and we'll put them to the speakers as we go along this afternoon. We're also wanting to use Slido, and we've got a few questions that you can answer using Slido on your mobile phone. And I'll just talk you through how you can use Slido. You'll need a separate device to the computer that you're watching the presentations. And if you just go to Slido or put Slido into Google, it will come up and you'll get a screen that looks like this. You don't need to have any special apps or anything else installed on your phone. And you just enter the code for this meeting in the box, and the event code for this meeting is 2653. So if you want to make a note of that number, whenever we want you to answer a Slido question, we'll ask you to put that number in. And we'll start just with a simple question just to see if the Slido is working. So if you want to go to Slido and put the code in, and these are strange times. We haven't met in person for almost a year now. We're running all of our conferences now on Zoom or similar media, and just interested to know where you traveled to a conference before COVID back in 2019. So if you could just answer this question on Slido, and we'll see if we're getting your responses. So I'm just going to go to and that is so there you should be able to see where we've all traveled. So most of us have been to conferences in the United Kingdom, but we have been traveling quite far afield in the conferences that we're attending. So I'll give you a little bit more time to find Slido. As we say, if you go to Slido on Google and you can put the code 2653, and we'll use Slido polling a little bit later on in the program. So quite a lot of us have been traveling to Europe. Some people haven't been to a conference. Very small number actually went to the USA in 2019. So you can carry on answering that poll. We'll leave it open and I'll come back to that later on in the meeting. But if you've got your device, we can use Slido at various stages this afternoon. So the topic for this afternoon is a very important one, and that's delivering sustainable healthcare, which basically is health that's good for health, it's good for the planet and good for the future, and helps us to meet our targets of a net zero carbon NHS. We've all seen many graphs, such as this one, relating to climate change, which shows changes with time, dating back on the left all the way to the mid-18th century, leading up to the present day, with the gradual rise in greenhouse gas emissions, which have been associated with climate change, which is the dilemma that we're now facing and that we're going to talk about today, and how we can help address this issue in healthcare. So the main reason for the symposium on sustainable healthcare is to make everybody think about what they can do themselves in their own personal lives, in their own clinical practice if you're working, whatever area that you're involved with, to think, what can I do? What can I do myself to help us reach the target of a net zero NHS by 2040? So this is how the program's going to pan out. We're shortly going to change over to Chantal Rizan, who's going to tell us about the carbon footprint of healthcare. We've got Dr. Raja for the Manchester Climate Change Agency and what's actually happening locally in Manchester. We'll have a short break, and Claire Igo from Sustainability at MFT is going to tell us about what actually happens to waste. And my colleagues Cliff Shelton and Rebecca Sutton are going to talk about embedding sustainability in learning and practice in healthcare. And after a further short break, we'll finish with my presidential address, 2021, A Waste Odyssey. I'm afraid Kevin Anderson from the Tyndall Centre for Climate Change can't be with us this afternoon, and he's had to withdraw at short notice, but we do hope to be able to bring him at a later date. So the first speaker this afternoon is going to be my colleague from Brighton, Chantal Rizan, and I'll just stop sharing my screen now and hand the screen over to Chantal. And while Chantal is loading a presentation, I can tell you about Chantal, who's been very actively involved in the climate change agenda in healthcare. Chantal's currently an ENT research fellow at Brighton and Sussex University Hospitals, where she's undertaking a PhD seeking to identify carbon hotspots within the operating theatre. She's been very actively involved. She's working with the Royal College of Surgeons of England and is a founder member of the Royal College of Surgeons of England Sustainability in Surgery Working Group. And she's also involved in the Environmental Sustainability Steering Group in a local NHS community. Chantal works very closely with the Centre for Sustainable Healthcare as their Sustainability Surgery Research Fellow. And Chantal is going to tell us about the carbon footprint of healthcare. And please do think about your area of activity and what you can do yourselves wherever you're working. So it's over to you, Chantal. Thank you very much.
Well, thank you ever so much for the kind invitation to speak today. And it's a pleasure to be joining you all here from sunny Brighton. As David mentioned, I'm currently undertaking a PhD looking at ways to reduce the environmental impact of the operating theatre. I appreciate that you'll all be coming from different backgrounds working within healthcare. And so I'm hoping that you're able to see then those parallels and where you might be able to apply some of these principles to your own clinical work. So just by way of background, just to take you back a few steps, So I've always loved spending time in nature and outdoors. And you can see in the top left picture of me when I was just 4 years old. That was my first pair of walking boots. And around that time, I was also given a book where I was first introduced to the concept that actually, as humans, we're damaging the planet around us. And this obviously sparked an interest because by the time I was 12, I then wrote a 28-page manifesto that was looking at the impact of overfishing on our waters and on global warming and deforestation and so on. By the time I was 16, I then set up a young enterprise company, and there I was looking at recycling juice cartons, and that was in collaboration with a women's cooperative in Cairo. And our company name was Zabaleen, which was Arabic for rubbish collectors. But then I became a doctor. And in my personal life, I continued to do various things to reduce the amount of plastic that I was using, to shift towards active transport, and to generally try to have a plant-focused diet. But I couldn't see how I could then apply those principles in the workplace. So on the left-hand side, you can see an image of 101 pieces of single-use plastic that were generated in a single adenotonsillectomy operation. That's from a paper recently published in the Journal of the Royal Society of Medicine. And I couldn't really see how these insurmountable volumes of waste, how I could actually do anything about it. But then I did a master of research. I was using lean management techniques at that point to see how we could better optimize our use of resources, and that was focusing on finances and on our time efficiencies. But I saw that actually there were environmental savings associated with that as well. So I went on then to look at how I could to focus my efforts then on the environmental side, and I went on to develop a PhD in that field. So I want to just start off by essentially stating its relevance to you as a clinician. The Lancet countdown on health and climate change has posed climate change as the greatest threat to human health in the 21st century. And that's through all sorts of different mechanisms, including heat waves, storms, flooding, as well as change in our vector-borne infectious diseases. Air pollution is the greatest cause of environmentally related human death, and it's thought to be associated with around 7 million excess deaths each year. And just to put that in context, in terms of COVID, there are around 2 million deaths so far from COVID-19. And of course, with this, we're able to have a simple diagnostic measure, whereas that's not the case with air pollution. And there's actually only recently been a landmark case where air pollution has been accepted and recognised as having made a material contribution to the death of a young girl who was just 9 years old. He died of an asthma attack, and it was found that actually her exacerbations of her asthma were then correlated with the local levels of air pollution. But whilst we know that actually climate change impacts on human health, the provision of healthcare itself actually paradoxically itself is further exacerbating climate change. So we know that the NHS alone produces around 27.3 million tonnes of carbon dioxide equivalents each year. And that equates to around 4% of all of our greenhouse gases within England. Of course, we've got the great Greener NHS Meeting Net Zero report that was released earlier last year, and that set the ambitious target of reaching net zero within the NHS by 2045, taking into account as well the emissions that are upstream within the supply chain. And we're actually the first healthcare system to make such an ambitious target. We're also we're very much contributing to air pollution. We know that around 3.5% of all road travel within the UK is in relation to NHS journeys, either through patients or through staff. And within a recent publication of mine, we estimated there that around 2% of global plastic production is associated with healthcare. And there are other ways in which we're impacting on the environment in a detrimental way through ozone depletion, mainly due to our use of nitrous oxide. And we're further contributing to scarcity of resources, as well as environmental persistence, bioaccumulation and toxicity of things such as propofol and antibiotics, which they persist in our waterways. And of course, there's issues in relation to our overuse and our misuse of antibiotics. So I'm going to now just give you a little bit of background in terms of the scale of the problem within operating theatres. So I'm going to be using this now as a case for looking at how we might be able to reduce the environmental impact within surgery. We know that operating theatres are a really resource intensive area of a hospital. We use around 3 to 6 times more energy than the rest of the hospital due to our use of heating, ventilation and air conditioning. And we also generate around a quarter of medical waste. So we generate a lot of waste, which is mainly an issue in terms of the amount of resources as opposed to the waste itself, which I'll come on to. And I recently published a systematic review looking at the papers that are evaluating the carbon footprint of the operating theatre. And here I found that a single operation contributes between 6 and 814 kilograms of carbon dioxide equivalents. And that's per operation. So for each operation, that equates to driving over 2,000 miles in an average petrol car. And across those studies that were included within the systematic review, we're able to see that the hotspots there were the electricity use, procurement of consumables, as well as the anaesthetic gases. And what I want to just draw your attention to is that actually those latter two, they are within the domain of clinicians. We know, looking across the whole of the NHS, that actually around 2/3 of the carbon footprint is in relation to the supply chain and our pharmaceuticals and our consumables. And really, those are things that we need to be taking responsibility for and that we can actually do something about. Across the whole NHS, our electricity use and our building is just around 10%. And so it's important that we are working alongside our colleagues in facilities and estates to actually reduce those areas. But this really is something that is within our locus of control as clinicians. So I want to introduce you at this point. So it's all been a little bit doom and gloom up until this point, but what are we actually going to do to improve things? And this is a framework that was put together by the Centre for Sustainable Healthcare. And I think it's really helpful actually in terms of framing the ways in which we can actually improve sustainability. And so whenever you're making any changes, whether that is a quality improvement project or an audit or research, alongside your day-to-day actions within the workplace, I think it's really helpful at each stage to consider balancing the patient and population outcomes against the triple bottom line. And by that, I mean the environmental, financial and the social sustainability. So we're going to go through this in detail now. But just at this point, I want to draw your attention to a few things. So this is a hierarchy, which I recently published in the Bulletin, which is a publication of the Royal College of Surgeons of England. And essentially it outlines principles of sustainable surgical practice. But we're going to go through these in order of importance, but at this point, I just want to draw your attention to the bottom. So the very most important thing that we can do is to focus on disease prevention and on health promotion, and actually recycling and better management of waste. That is really just a last resort, and we're going to have a much greater impact through focusing on reducing the need for healthcare in the first place. And we do need a fundamental shift, I think, in terms of our definition of healthcare, away from disease treatment through to actually promoting and maintaining well-being. And that, of course, is going to require us to invest further in terms of our public health measures. And we need to be really encouraging our patient groups to actually shift into some of those more healthy behaviours, such as reducing red and processed meat consumption, adopting active transport and increasing general levels of exercise, as well as smoking cessation and alcohol moderation. And the really great thing about this is the key benefits that it has in terms of actually improving an individual's patient health, but actually it reduces the environmental impact at the same time. And I think we do have a responsibility actually to be engaging in some of those public health debates and campaigns. So The other thing that is important to do that is a really sort of low carbon intervention to reduce our environmental impact of the healthcare that we provide is to actually be harnessing the patient themselves, and to be encouraging them to actually do whatever they can do within their own control to optimize their own conditions. And we need to be working with our patients to really optimize them ahead of any intervention. So, for example, we can seek to reduce our complication rates from surgery through getting that patient into the best possible state in the run up to their operation. And that might include things like smoking cessation and increasing exercise, of course. Every patient encounter should also be seen as an opportunity to improve compliance with medications. And the other thing that we can do is to work with our patients to ensure that they're actually accessing healthcare in an appropriate way. And we can work with our GP colleagues also to that end. So once the patient's actually entered onto a given patient pathway, we can then think about actually streamlining the various different components from the moment that they get referred from primary care through to their final discharge. And we need to be seeking to minimize any unnecessary appointments. So, for example, a patient who has a given investigation that's got a very low chance of actually it coming back positive, actually talking to that patient and asking if they're happy for you to just let them know by writing if the result is negative, rather than getting them to come back into the hospital for another appointment, only to be told that the result was negative. And this, of course, reduces the amount of travel, but also the disruption to perhaps their work and their family lives. We've, of course, seen a massive surge in terms of the uptake of virtual clinics due to COVID-19. And my hope is that these will be adopted at least for a subset of all of our consultations on an ongoing basis. And that's been a real positive that has come over this last year or so. And we can also then, once a patient is undergoing a given procedure, we can think about streamlining the actual consumables that are used, whether that's a simple procedure to examine a patient or a full complex operation. And we need to actually question whether we truly need to open things before we actually open them. We often see people being over prepared and having lots of things on a trolley, but some of them just going directly into the bin. We also need to be streamlining our single-use sets. So on the right-hand side, you can see there a pack that is used for carpal tunnel decompression within my trust. None of the surgeons at all use the white sponges, and so we need to have those better lines of communication with industry to make sure that there's nothing in our pre-prepared single-use sets which aren't actually needed, because it's of course a total waste. So we certainly need to be streamlining and removing the unused items from our single-use sets, but actually the reverse is true for our reusable sets. So this is some work taken from one of my PhD studies, where I'm looking at the carbon footprint of decontaminating reusable instruments and looking at the impact of streamlining sets. And essentially, when you put a reusable set into a decontamination machine, it uses the same amount of resources per slot, regardless of the number of items that are on that set. And so through actually removing certain items and then opening them as a supplementary singly wrapped item in those few cases where they're actually needed, there's an increase in the carbon footprint as well as an increase in the cost. So traditionally, we thought that streamlining was great for our reusables as well, but actually the reverse is seen. So this really does point to the fact that we do need to be developing the actual evidence basis, and we need to make sure that when we're acting to actually reduce our environmental impact, it's founded on the evidence as opposed to our hunches, because often in environmental accounting, there's lots of surprises. So far, we've been focusing on making reductions in terms of reducing the need for care and reducing the steps or the amount of consumables. But we'll now turn to think about low carbon alternatives. And that includes then switching to things like reusables as well as recycling. So in terms of actually considering low carbon treatment options for a given condition, one of the best things that we can do is to actually focus on the clinical effectiveness, because if we ensure that the healthcare that we're providing is truly necessary rather than avoidable, this will reduce the carbon footprint, and it saves the need for further interventions which themselves have got their own carbon impacts. There's also, we've got to consider that there will be a difference in terms of the actual carbon footprint between different surgical approaches. So for example, if we look at minimally invasive surgery and robotics, they typically are thought to have higher impacts compared to traditional approaches. But the jury's still out on that one, because actually a lot of the studies aren't taking into account the impact on the length of hospital stay, as well as the complication rates. And so we don't know for sure. We need further research in that field. But at the moment, we think probably the minimally invasive options are more carbon intensive. And the other thing to think about is perhaps surgical versus non-surgical options. And I think the key determining factor here is the acuteness of the condition. So of course, surgery is a very carbon intensive model of care, but for acute conditions, it's likely that the non-surgical options have got a lower carbon footprint, but actually for chronic conditions, the two will balance out. So this is a study that was published looking at the medical versus surgical treatment for gastroesophageal reflux disease. And what we see here is that after 9 years or so, the carbon footprint of the surgery becomes lower than that of the medical treatment. Of course, during COVID, we have seen a shift towards some more medical treatment. So for example, for acute appendicitis, and that is an interesting point in terms of the balance between the carbon footprint of the alternatives. So we'll now turn to think about reusables. These are all papers that are based on life cycle assessments of items used within surgery, either linens or instruments or perioperative consumables. And these are all studies that take into account the full life cycle, including the sterilization, as well as the decontamination of any reusable instruments. And here we see across these studies that the carbon footprint is lower for the reusable items. The reverse has actually been shown to be true in some Australian studies, and that's mainly because of the electricity that's used during the use phase, so during the decontamination, because they're using less renewable resources, sources of energy. But we do know that actually if you remodel those using European energy grids, then actually the reusables again are better. So I would urge you to look around, and if you're using any single-use items within outpatients, or you typically see them quite commonly in A&Es, just question their use, and especially where there are actually decontamination facilities available within the hospital. Now this is a graphic that's taken again from within some of my PhD research, and here I'm looking at the consumables that are used within a tonsillectomy operation. And as you'll be aware, then actually within this operation, we're using a reusable instrument set, but actually the reusables contribute just 16% of the carbon footprint. The majority of those impacts are then due to sterilization. But what is dominating the carbon footprint then are the single-use items that are opened on the side and in addition to the reusable set. And I was able to do some hotspot analysis to see, well, actually, were there key items that were contributing a lot? And we found that actually a third of the carbon footprint was attributed to just a small number of items, and they were the suction tubing, as well as the table drape and the patient drape. And sterile gloves also. So the majority of those ones that were contributing a lot were large, bulky, single-use plastic items. And so it may be that actually we can do this sort of analysis across a whole range of operations and see where there are obvious switches that can be made. So of course there are reusable options available and readily available for both the table and the patient drape. And this is just a picture of some other single-use bulky items that I identified across looking at laparoscopic cholecystectomies, inguinal hernia repair, hip and knee replacement, and tonsillectomies. And these are the sort of areas that we should be tackling to make changes. So within my research, I also look at sterilization processes, and I'm just drawing your attention to this to show that there are sometimes some really simple switches that we can make between single-use and reusables without actually impacting on patient care in any way. And actually the carbon footprint of housing one of these instrument trays in a reusable rigid container is around 1/4 of the carbon footprint as opposed to using these single-use polypropylene tray wraps. And the situation is even worse when we actually decontaminate instruments in individual wraps. So these are then polyethylene pouches, which you often see double pouching. And actually the carbon footprint of the whole decontamination process is then around 4 times that of preparing the instruments as part of trays. And that's partly because of the actual sterile barrier system, as well as the way in which the decontamination machines are loaded. So we also need to be thinking about applying circular economy principles. We're currently working globally on a really linear model whereby we actually we extract resources out of the ground, we use them once, and then we dispose of them. But we have got finite resources, and we do need to be thinking really carefully about maximizing our resource use. And we can do that through good maintenance as well as repair of our surgical instruments and reprocessing also. So most hospitals have got repair contracts in place, but they're really often underutilized. This is a picture of surgical scissors being repaired. It doubles the lifespan, and they can actually be repaired up to 10 times. And so that's drastically increasing the lifespan of those scissors. But you often see it in theatres that the surgeon will say, okay, these scissors are blunt, and actually they'll then expect for them to be disposed of. So we need to raise awareness that actually these things don't need to just be put in the bin. We are actually able to repair many surgical instruments. When it's clinically unfeasible or inappropriate to use reusable items, the other thing that we can think about is actually using hybrid items, which have got that the predominant part of them is reusable, and then there's just a single use insert for the really critical area. So for example, in certain laparoscopic instruments, you might want the scissor tips, for example, to be single use, and so rather than just using the whole thing as single use, we can use ones that got reusable handles and shafts, just with a single use insert at the end. Now I've deliberately left this until last, and I think when we talk about sustainability, people often do jump to thinking about waste. But actually the Sustainable Development Unit estimates that waste is responsible for around 0.1% of the carbon footprint of the NHS. Healthcare Without Harm suggests that it's more like 4%. So it's very small. So even if we recycle optimally, that's only going to reduce, say, around 4 or 5% of the carbon footprint of the NHS. But having said that, it's really important that we do get it right. I recently published a study looking at the carbon footprint of different healthcare waste streams. And here I found that actually there's the opportunity to have a 50-fold impact in terms of the carbon footprint of the waste itself, with recycling, of course, being the lowest and high temperature incineration waste streams being the highest. And I just want to draw your attention to now, the issue isn't the waste that is produced. That's generally, the volume of waste will be a proxy of the amount of consumables that you're using. And so actually the embodied carbon is more held in the production of those items in terms of the raw material extraction, the manufacturing, as well as the distribution and the use phase. And actually the contribution from waste is very much smaller. But we've got a huge opportunity, and within the operating theatre, there's a large amount of potentially recyclable plastics. So we do need to be getting this one right. So in conclusion, there's no simple solutions. We're all going to have to play a role through lots of iterative changes. And after today, I really want, what I'd like is that people sort of start having those conversations with colleagues. And I think it is a really snowballing type effect. And once people are aware and take responsibility for their environmental impact within the operating theatre or within your own workplaces, I hope that people then apply essentially green lenses whereby they can't help but look around and see opportunities to actually make changes. And of course, as well as those small acts, we need individuals to come forward and start making larger changes, both at a local and national level also. So I'd just like to thank my supervisors, as well as my PhD funders, Health Education England and the Royal College of Surgeons of England. If you want to read more, I put a few of my papers on the slides, and I'd also like to draw your attention to the SHARE conference. That's the Sustainable Healthcare Academic Research and Enterprise Conference, which we're hosting down here in Brighton on the 7th of May this year. So I'd now like to welcome any questions that you might have.
Thank you, Chantal. That was fantastic and a really great start to this afternoon's symposium. Please do use the Q&A function in Zoom, and we'll be looking at that, and then we can put questions to the speakers. Could I kick off, Chantal? And my other panelists are welcome to join in. How are you managing to put this into action in Brighton, where you're working? Yeah,
certainly. So I'm, of course, my focus is the PhD, and it's actually gathering the research so that we actually have a strategy, or we make sure that when we're making actions that we're focusing on those areas that are the hotspots and where we're actually going to make the biggest impact. I founded the Sustainability in Surgery Working Group at the Royal College of Surgeons of England, and so the findings of my study, they are directly informing our national policy on this, and I'm working also with the UK Health and Climate Change Alliance, and we're looking at setting up a working party to look at how we're going to meet net zero within surgery. And then locally, I've helped to set up the Environmental Sustainability Steering Group. So that's an ESSG, and we're currently putting together our Sustainable Development Management Plan, which is seeking to improve the situation more locally.
Somebody has asked if we can have access to the slides afterwards, and I think we are going to make them available through the Society website. In terms of repairing scissors, I've obviously been very guilty of complaining about scissors throughout my surgical career. What do you actually do with them in Brighton? Is that a facility you have on site, or do you have ready access to someone who can repair the instruments?
Yeah, so there's only actually a few places that have on-site repair processes in any sort of serious way. So that's at St Bart's and also at Cambridge, amongst perhaps another couple. So the more common situation is that there is a repair contract with an external company, and the items get sent off. And that's what we have here in Brighton. But certainly I've seen various situations where then they're not used, but there are obvious opportunities to actually be sending, and our rate at which we're actually repairing our instruments is nowhere near what we could actually be doing.
Somebody has asked about how you get on with your colleagues, and have you encountered much resistance from other surgical, medical or nursing colleagues?
So I think there has been a huge transition, actually. I think if I was trying to make some of these changes 5 years ago, then there would have been a lot of resistance to change. I think that over this last 2 years, there's been a huge change in terms of people's or the general public's perception of the importance of issues in relation to the environment and our responsibility towards climate change. And I think that there's been a slow realization that actually this also applies in the workplace, and actually healthcare isn't exempt, and we need to be applying some of these things that we all do in our own homes when we actually go into work. Of course, during this last year, there has been a real saturation in terms of people's capacity to do things that are perhaps shifting their actions towards sustainability. So I think on the ground, things have been a lot more challenging during this last year, but actually it's really encouraging that at a national level, in terms of the various Royal Colleges, as well as other national bodies such as the Association of Surgeons of Great Britain and Ireland and ASSET, there's been a much greater engagement and willingness to learn about what can be done. And so I think at a national level, as well as local leadership level, there is a greater willingness to come on board with some of these things.
Somebody wants to know if there's been any modelling for the effect of the COVID pandemic on healthcare carbon footprint. Is it going to be worse, better, or neutral?
So there's various ways in which it will have been beneficial and negative. Without doing the numbers, I wouldn't be able to tell you in terms of where that balance lies. I myself did actually do a life cycle assessment looking at the PPE specifically, so looking at the environmental impacts of the PPE that we used during the first 6 months of the pandemic, and within that, I was looking at various different strategies in which we could actually mitigate the environmental impacts. And from that, I was able to show that actually the additional carbon burden was equivalent to around an additional 1% of the total carbon footprint of the NHS. But encouragingly, I was able to show that actually through strategies such as using UK manufacture, reducing our use of air freight, as well as shifting to reusables, so using the reusable gowns that we use instead of single-use gowns, and as well as recycling, we're able to make significant reductions in terms of the impact of the PPE. And there's obviously been other good things that have come from the pandemic in terms of virtual clinics, as well as shifting perhaps to models of care that are less carbon intensive, but we don't really know the long-term impact of that. Of course, there's going to be a delay in terms of those carbon impacts because people are presenting later, and there's just a shift in terms of when those carbon burdens actually come about. So I couldn't say overall, but there's certainly been some pros and some cons as a result of the pandemic.
There's lots of questions, and I don't think we'll have time to address them all, but we'll see if we can answer them in the Q&A function afterwards, perhaps. Someone's asked, can you repair single-use surgical items and make them reusable?
So this is then referring to reprocessing, where you take a single-use item and you decontaminate them, or you make them fit for purpose for reuse. And that's something that is quite commonly done within the US, but there's slightly stricter requirements or legislation surrounding that from the MHRA in the UK. We have seen, and it's common accepted practice to actually reuse face shields that are designed for single use, and those are used with decontamination wipes and what have you, sort of 5 times or so. So it's something that we really do need to explore in terms of single-use items, and actually are we able to give them a second lease of life, or a third, or a fourth, or a fifth?
That's fantastic. So what do you think about the carbon footprint of robotic surgery as the last question before we move on to the next speaker? One senses it would be worse, but do you think it's here to stay, or going to be challenged?
If we look at the impact of the operation itself, there is reasonable evidence that the actual carbon footprint is greater than, a laparoscopic approach or a laparotomy. That has, that study has been done comparing those different models. But what they don't then take into account is whether that patient then goes on to have a complication that requires further surgery, or the length of hospital stay. So really we need to increase the system boundary of those studies to look at components of the patient's journey beyond the operating theatre. So within the operating theatre itself, then yes, the carbon footprint's likely to be larger, but we can't really say at this. We need further research essentially to give you a definitive answer.
That's fantastic, Chantal. We've got lots of questions and we might see if we can get you to answer them afterwards. Yeah. Somebody's asked if I'm screening Slido for questions as well. I can't do it at the same time, but please do put any questions that you've got in the Q&A function on Zoom and we'll try and make the slides available. So thank you very much, Chantal. And we're going to move on to our next speaker. And it's a pleasure to welcome my colleague, Dr. Murugesan Raja, who is a GP working in Manchester. And he's been very active as a clinical lead for respiratory medicine in the community in Central Manchester Clinical Commissioning Group. And Raja is also the Health and Wellbeing Board member on the Manchester Climate Agency. As you know, Manchester declared a climate emergency and we're trying to get to net zero. And Raja is one of the key players in Manchester who can tell us about what we're doing locally, which I'm sure will have relevance to wherever you are living or working. So Raja, thank you very much for joining us today. Please do put your questions in the Q&A function in Zoom and I'll have a look at those as we go along. But over to you, Raja, to tell us what's happening in Manchester.
Thank you. I'm just trying to get the screen share right, so bear with me.
No worries. So it's, you might hear the rain above my head. It's raining very heavily here. And for those not in Manchester, I've already said that it's not actually the wettest place in the United Kingdom.
Okay, I think you should be able to start to see it now.
So I can see your slides.
Yeah, you can see it now.
Yep.
Any better?
There you go. Yes, that's fine. We can see you.
Excellent. And
thanks.
You can
Raja.
see it move as well.
We can see it move as well.
Thank you so much, David, and thank you so much for inviting me. I'm, like David said, Murugesan Raja. I'm a GP, but my background was in respiratory medicine, which is what made me interested in the effects of air pollution. And now, obviously, we even talk about the carbon footprint of each inhaler that we use, about whether we use an MDI or a dry powder inhaler, and the carbon footprint that each dose has. And somebody was asking questions about waste, about medicines being delivered. So all of these things were very interesting, and everything that we do as clinicians or as individual people has an effect on the environment that we live in. So I'm mainly a GP at the moment, but also got involved with commissioning. So work with Manchester Health and Care Commissioning, and that's how I work as a board member for Health and Wellbeing Board for Manchester. And through that, they nominated me to be part of the Manchester Climate Change Partnership. So I'm going to kind of give an overview of what's happening with the city and what we are doing as Manchester. Greater Manchester is also involved, and collaborative work happens between Manchester and Greater Manchester. But I'll try and speak about what's happening with Manchester. These slides have been prepared with the help of my program director of the Manchester Climate Change Partnership, Johnny Sadler, who was supposed to speak today as well, but he couldn't come for some reasons. But I'll go through the presentation with you, and if you have any questions, of course, please feel free to share that, as David's been saying. So what I'll go through is the agenda, and you can probably talk about the background, the context from 2010 to 2020. They'll talk about the strategy that we have for the next 5 years. And then I'll talk about the social and the economic benefits that we have because of what we do with climate change and the Manchester Climate Change Partnership itself, and what you can do to actually get involved in this. So that's really the background, which is, with regards to 2009, it's as about more than 11 years ago when we actually said that there needs to be a call to action about what Manchester could do. And that led to this document called as the Certain Future, which is that we need to be doing something which is science-based and not just what is political at that time, but we need to be doing something which is science-based. And this can't be done as individual actions. This needs to be a collective action by the whole city. And then if you could see this graph, I think if I could just hover through these, my cursor is very sensitive. It's to say that if we have there, which is the darker purple, that is the direct carbon emissions that's coming from industrial sector, and the one about is the domestic sector, and the one about is the transport sector. And if I just show you that darker line is the projected or is the kind of the target that we need to be for carbon emissions if you start from 2005 onwards to 2020, and you can see that we are still far away. We've done a lot of progress in bringing it down, but we're still quite further away from where we really need to be at if we actually have to move towards a zero carbon in Manchester. So in with all those challenges we had in 2015, we had set up the Manchester Climate Change Agency, which is the backing that it needs to be an individual organisation, separate from the city council, but kind of working together as collaborative partners to be able to think about targets, think about what strategy needs to be, think about the governance behind it, and how can you drive action. And when you've driven the action, what is the progress? How do you report on that? So that is all what Manchester Climate Change Agency was established in 2015. So it's about 6 years since the establishment of this. So in March 2016, Manchester committed saying that they will play its full part in limiting the impacts of climate change. And you'd remember that Paris Climate Change Agreement was all done just before, and Manchester kind of committed to say that they would play their role in limiting the impacts of climate change. So in a nutshell, again, 2018, if I roll it forward, we defined we defined the same things, which is what do we need to do, and then that was established as a new targets in March 2019. We worked very closely with Tyndall, who set the carbon emission kind of projects and the footprint that we need to kind of bring down, and all the other the maximum budget that we have with regards to carbon ton emission as well. So I'll kind of talk about that in a little bit more detail as we go forward. And then a Manchester Climate Change Partnership, as it used to be called as the Manchester Climate Change Board. So we then realized that the more number of people we can get involved, it's better to kind of broaden the network, and that itself would have an impact on the climate change as a whole on the city, and that could influence the whole country and of course globally as well. So that's really the background and the context that Manchester Climate Change Agency or partnership, how it kind of came into being. But I kind of would like to talk about the strategy next. So this is the draft Manchester Climate Change Framework, which is 2020 to 2025. It is a big piece of document, but it was published last year. Even though with COVID pressures, we felt that it's very important to keep focus on this. So the strategy is out there, which is basically towards making Manchester a thriving, a zero carbon, and a climate resilient city. If you have time, I'd recommend that you could actually go and look at the framework. And if you have any questions, of course, please feel free to ask me, or we can go through them if I don't have all the answers to those questions now. So this is the commitment that we would play a full part in limiting the impacts of climate change, and will create a healthy, because climate change automatically has an effect on our health. The more healthier we are, the impact on climate change is also less. Using more green spaces, how we can be socially inclusive when we talk about climate change, and how we can be socially just in this climate justice, as we talk about, as a city where everyone can thrive. And that is really the aim of Manchester Climate Change Partnership. If I move to the next slide. So what are the objectives for us? I mean, our objectives is that we stay within our carbon budgets. Like I said, I'll talk a little bit more detail about what our carbon budgets are and what we're allowed to spend, and how we can kind of bring them down further, and what is the challenge that is ahead of us as a city, as a city as big as Manchester, and how can we do the things that are needed to adapt, and how can we be resilient. Health and well-being is one of the key things. As a doctor, I know the effects of the poor health on the NHS, but what are the effects of the NHS itself on climate change, which is what Chantal covered so well before. And we kind of work as different hospitals and different trusts, including GP practices, and how we can work as a collaborative system to actually make sure the carbon footprint, because of delivering health, is less, but the effect of climate change itself on health is also kind of getting more and more obvious. How we can create an inclusive system where we have zero carbon, and how we can have an economy which is actually climate resilient and green. So if you could see that slide, well, it's talking about the different types of emissions. I think most of the time we talk about the direct CO2 emissions, which is on the left side on this graph, and we emit about 2 million tons per year. And then we've got the Manchester Airport, where we have aviation emissions, even though Manchester residents themselves contribute only 0.2 million tons of those emissions. But if you could see the two starred things, these are flights taken by non-Manchester residents, but they use the Manchester Airport to fly from. So you can see that's close to about 3.5 and a little bit more with regards to the carbon emissions that happens because of aviation. The other thing is about indirect emission, which is not just the infrastructure, the transport, and the other things which are directly responsible, but these are consumption based. And I think Manchester has a view on how every act has a consumption. So the type of food we eat, the type of transport that we use, all of these things have a consumption based CO2 emissions, and they are also pretty much close to 3.3 or 3.4 million tons of carbon dioxide emissions. So as a Manchester Climate Change Partnership, or Manchester, we're interested in how we can bring these things down as a cohort, and how we can make sure that our focus is on all of these different types of emissions, and not just on direct CO2 emissions, which is where most of the focus would be nationally, as well as in other cities and even globally. But we want to be talking about all these three. So going back to direct emissions, in our budget's about a maximum of 15 million tons of CO2, and that is from our homes, our workplace, and ground transport. And this budget was from 2018 onwards. So that makes it clear that we need to kind of reduce our direct CO2 emissions by at least 50% between 2020 to 25. Well, I showed you the graph where we need to be and where we were. So in order to be able to get to the target, we need to be drastically working towards how we can bring our carbon emissions down further and further so that we stay within our budget. I think the easiest way to describe this would be if we get paid on the first of each month and we end up spending our income in the first week itself, we would be struggling to spend the rest of the 3 weeks. So it's kind of similar to that we have a budget that we need to kind of hold on to. And if we spend a lot within the first few years, it becomes more and more tighter as we go along. and that's what the next lines are, that we need to probably decrease 6.9 million tons during 2018 to 22, and a maximum of 3.6 million tons during 23 to 27. So that is what will be allowed, and that is a challenge that we have, but Manchester is committed to kind of deliver on these kind of budget and the targets that we've set ourselves. So if you can see the graph, it kind of goes down and down. So 2018 to 22, we've then progressed in bringing the emissions down to about less than 7, but we want it to be further and further and further down. So between 2048 to 21, we're pretty much in the zone of zero carbon emissions. So that's what I talked about, how we can actually stay on the budget, which is the projection. So if you see on the left side, it's talking from 2017 onwards, and 2050 is where we need to be. And if you can see that year on year, we need to decrease it further and further, and it's 13% per year from 2018. And if we delay that till 2022, then our decrease needs to be 18% per year from 2022. And if we delay it further to 2025, then we need to decrease it by about 31% per year from 2025. So the action is actually now, which is why the climate change emergency was declared, and that was declared in Manchester as well, because the sooner you act, the more leeway you've got to kind of work with this. The later you leave it to, the more difficult it gets. Okay, so I talked about aviation and consumption-based emissions. Aviation sub-objectives is that we want the emissions from all flights from Manchester Airport. It doesn't matter whether they're Manchester residents or non-Manchester residents, to be fully aligned with the Paris Agreement. Airports are a bit tricky because if we focus on shutting down flights, for example, in Manchester, then Liverpool would have a bigger airport to cater to the needs of the Manchester residents. So it has to be a whole UK-wide kind of strategy, but at least we have some kind of control over Manchester Airport through Manchester City, and because of that, we have some control of that. But it has to be a national kind of way of saying how we can all work together to be able to bring those emissions down. The question that got asked about how far did we travel for conferences, and now how do we do conferences like these virtually, has a big impact on aviation sub-objectives and their consumption-based emissions, is what I'm going to talk about next, which is the indirect emissions that I briefly touched upon. It's about what kind of goods that we use, what kind of services that we have. Are we able to indulge in things which are sustainable, recyclable? How can we change the way we live? What are the practices that we can change? How we can get involved? All of these things has an impact on the indirect consumption-based carbon dioxide emissions. So we all as individuals, we all as a collective, we all as healthcare professionals, or we all as an NHS have a role to play in those kind of indirect emissions as well, which is what I would like you to take back from, if from today. Then it's about challenging ourselves about what we can do differently and how we can approach that as well. So the next is how do we adapt and resilience. I was talking to David earlier about even thinking about how, if North Manchester General Hospital gets built, how we can be sure that it is green, how we can make sure that it's sustainable, how we can make sure that the carbon footprint from something like that is actually much more efficient. So how we can adapt the whole infrastructure, what we can do about the natural environment. The lockdown has shown very clearly the impact of not traveling as much on climate change. How can we be adapting to different ways, and how can we be working differently, and how that affects the resilience itself, of our residents, of our organizations, and how we can work together to be able to build that. And that is a day-to-day conversation, and that is a kind of change of culture that needs to happen. But that is what we are hoping to strive to kind of move things in Manchester to be able to get to that point where we're adapting well and we are resilient as well. Health and well-being, I can't talk more about that, but it is so important that if you take actions to decrease decrease our carbon footprint and decrease the impact on climate, and you kind of affect climate change, it improves the health and well-being of everyone in Manchester. Even things like using more green spaces, cycling, the ability to walk to your appointments, all of these things make an impact, and it improves the health and well-being of everyone in Manchester. And that's how we can also contribute towards the CO2 reduction, and that is how we can adapt to the challenges that's ahead of us, and that's how we can become more resilient, but also we can focus on those who are most in need. So we talked about what are the unnecessary appointments, but we can talk about many other things which are probably unnecessary, which you don't need to be doing, and how we can make it more inclusive so that people who really need the most are actually are able to get those facilities, are able to get those help. Another thing, when I talk about air pollution and talk about with passion, is people who don't have cars are the ones who are affected more by air pollution, because they live on the roads which is very busy, and those roads are used by the car users who actually emit those carbon emissions, which is causing those effects on air pollution, and that affects patients living in that belt much more readily than those who live in the suburban bit. So you can see how different things like that has a role to play, and climate justice and the people in deprivation being affected more, even though they are not really responsible for that kind of emission. So these are things to kind of think about when we talk about health and well-being as an agenda item within climate change. I talked about inclusive zero carbon. So climate change is not just my job or your job, it's everyone's job. So it's about feeling inclusive about it. It's going to affect all of us. So it's not just people who are interested in it who needs to be involved in it. It's about everyone's role. It's about moving forward with daily day-to-day practices that we can change, how we can influence our local politicians, how we can influence our practices, how we can influence the way everyone works. All of this has a role to play, and how it could be inclusive. So it's not just people in a certain strata or a class, or it's not just a white thing. It's how it could be a BAME thing. So it's about how everyone can get involved as a city in Manchester, as well as to try and obviously influence the whole of the country, and of course globally. And it's something that we all would benefit from, and how we can play an active role in decarbonizing and adopting the change to the changing climate. So what can we do? So that's pretty much very high kind of strategy level. But these are things that you probably will be much more easier to relate to. What are those 7 areas for action that we've set out, to meet the objectives and targets that I talked about earlier on? So that is talking about buildings, existing buildings, how they can be so carbon friendly. The new buildings, make sure that no buildings are built without thinking about the impact of carbon footprint, the impact on those buildings of climate change, how we can make sure that none of those gets permission unless they go through this filter of making sure that they are carbon friendly. How the Manchester's commitment is that any energy that we use comes 100% from renewable energy. How we can do that, there is an ask that the national grid completely decarbonizes. There's still work in progress, but how we can, think about, green roofs or solar panels, and how all of those things could be done well, so that we get most of our energy from renewable resources rather than those resources which are carbon intensive. Talked about transport and flying. What kind of transport do we use? Can we use the trams more? Can we use cycles more? Can we walk more? And how we can be making sure that it's inclusive, so that people who have access to bicycles or ability to walk, but also those who are unable to do that could also feel included in that bit. So all of those things has an effect. And flying, how can we impact on flying? There are people who fly very frequently. There are people who fly very rarely. We still might need flights, but how we can be more thoughtful and more resourceful about it. The food, what type of food we used, how is waste generated even in food, what kind of food that we use. whether we really buy the things that we really need to be using. Can we shop in the way that we don't waste towards the end? So individual actions, but they're all kind of has an effect on climate change. So it's about, visiting restaurants, how we can be resourceful about it. Lockdown has changed a lot of things, how we can change those practices. If we've moved into cooking ourselves, how we can use those practices that we've changed, that it becomes part of our daily day-to-day life. The things we buy and throw away, I think recycling comes in again and again. It's about what clothes do we have, where, how often we need to buy it, how often we need to throw them away, what kind of things that, whether we really need it or we don't need it. All of those things as individual actions that we can think about doing, and how individually we can change. And there are lots of resources on, you can calculate your own carbon footprint and think about what changes you can make to be able to influence the whole scenario around. The next is green infrastructure, how we can use more parks, green spaces in urban places where you see just buildings, how you can actually create pockets of green space, how we can create parks which actually recycle all the things that's available. So even harvesting rainwater and things like that. So there are so many things that we can do, and how we can support and enable residents within Manchester, and also working in the organizations in Manchester, and how they can all kind of take responsibility for their actions and their organization's action, and of course the actions of the city as a whole. So I'll move on to the social and economic benefits. I think in our conversation with David always was suggesting that Manchester was responsible for the Industrial Revolution, and of course it caused all the problems that we are in, but it also helped the economy. But then Manchester could be responsible for driving the low carbon sector that you can see in this graph. So by 2038, if we think about just low carbon sector, 17 billion pounds could be generated by sales, 100,000 jobs could be there in the green sector, and 6,000 businesses could be thriving just on the basis of making sure the sector is low carbon. So Manchester could be the force behind changing the whole thing, and that could be the reason for the green revolution, or a revolution to bring about change, to be able to decrease our footprint to the targets that we want to achieve. I'll obviously talk about NHS. Last count that I put in here is about 34,000 homes in Manchester are still in fuel poverty. And if we end that, then that automatically goes to the NHS, in the sense that we could assume that would save about 17 million pounds per year for the NHS, because of all the respiratory admissions, which could be prevented if fuel poverty could be addressed. Because for each degree change temperature down, there is increase in the number of respiratory admissions that happen. I'll briefly touch about air quality. Chantal talked about that 9-year-old girl, which is a very significant change, because we've so far always called air pollution as an attributable risk factor towards chronic disease, or towards premature mortality. But then about we can say that 10 people die prematurely every day, with air pollution being an attributable risk factor. And of course, the traffic congestion that we don't see that much nowadays, but that used to account for 1.3 billion pounds of economic loss. So you can see how big these benefits are, and how Manchester as a city can drive these changes, and how we can attract people in, how we can attract UK graduates into low carbon sector businesses and offices, and how as a new generation we think this as a norm, and we do things which are actually beneficial for the whole environment, and that actually is beneficial for all of us. So that's in a nutshell about strategy and our targets, and what are the 7 things that we would like us to do, and what the economic benefits and the social benefits are. But I'll just briefly describe what the partnership is. It's currently about 60 members across 10 sectors, and we are responsible for about 20% of Manchester's direct CO2 emission. The City Council is only responsible for 2% of those direct CO2 emissions. So you can see the scale of work that needs to happen to be able to get the 80% of the direct CO2 emissions that happen from different sectors. I'll go through that in a little bit detail as well about how we are trying to involve and engage so that everybody feels responsible and everybody works as an organization to bring change. It's a joint working between, like I said, City Council, Greater Manchester Combined Authority, the UK government, and different strategic partners in Manchester come together to be the Manchester Climate Change Partnership. And we now have a chair. We're moving towards having a director and deputy director to be able to make sure the work can happen at pace. So that is the breakdown of Manchester carbon dioxide emissions by sector. We do not have any direct control of that, but data comes through nationally, and you can see that the 29% there, about 623 kilotons comes from transport, 27% from domestic, and the rest of the 45% that you can see comes from. And if I break that further down, because of partnership work, you can see that even though we didn't have any control over that, but because of people in the partnership, like say arts and culture, Bruntwood, with health being there, NHS, faith work, City Council, and you can see all those purple things. These are all the things that we have control on because of the work that's happening within the partnership and how we can influence. Like say, we've got Manchester City Football Club, we've got Manchester Metropolitan University, and all of these things can work together to be able to bring organizational change, which decreases our carbon footprint and hence makes a difference on climate change. But we still need to work towards getting the other 80% involved. Progress is happening. So hopefully, if I do this talk a year later, it might be a lot different, but we are trying to get there. So how can you get involved? These slides will be shared as David says. There is a commitment to act. So, by all means, please feel free to sign. What are the actions? I talked about those 7 things, but there are about 15 actions that's been listed there. Wonderful, wonderful resource. Go on to that, click on that, see what are the actions that we can take as individuals or we can take as organizations, how we can influence. And all of those things are remarkable. I wouldn't say just think about what one action you would do, but think about what all you could do, because we all can work collectively together to actually make a big difference, which is not just responsible for us, but also for the whole economy and also for the health and well-being for the whole city. So that's basically, thank you for the time that you've given me now. And I'll try to stop the screen sharing, but by all means, please do get in touch with us, myself or Johnny Sadler, and we'll be more than happy to address any questions.
Thank you, Raja. That was fantastic and very interesting. If you put some questions in the Q&A box, and the relationship between Manchester Airport and the council being partly still an owner in Manchester Airport Group, are there any conflicts there in Manchester with their need to keep the airport going and addressing these difficult carbon reduction targets?
I think there'll always be conflicts, because I think with airports, you can always see them as income generating as well. But at the same time, we are also kind of, Manchester City Council and Manchester has a commitment to decrease those aviation emissions as well. Most cities don't have that much control over airports, but Manchester is in a unique place to have that control, so that we can actually directly influence airports and the emissions that comes from it. So the conflict is there, but then Manchester is committed towards decreasing those emissions anyway. So I think they're kind of above and beyond the conflict with regards to that goal.
There are a number of other questions around the politics in Manchester, and how prominent a role does the Manchester Climate Agency and Partnership have in the politics in Manchester? So
Manchester Climate Change Partnership has got councillors in it already. So city councillors like Angeliki, and we also have the deputy. We also have the treasurer already in the Manchester Climate Change Partnership City Council. So you've got really very strong commitment. And I sit on the Health and Wellbeing Board as well. So Sir Richard Leith, who's the leader of the council, is also directly involved with overseeing all of these as well. And I presented a paper on behalf of Health and Wellbeing Board, and Claire Igo, one of these speakers, also came to that. So there's a lot of commitment from the leaders in Manchester to actually make an impact, which is what is helping drive these changes. And also Manchester Climate Change Agency is thriving because of support from the City Council and other stakeholders within the organisation and within the partnership. And like I said, I'm being nominated as from the Health and Wellbeing Board member into the Climate Change Partnership. So all of those things kind of suggest that the politicians or the councillors very involved, and they are actually driving most of the things that I outlined as well.
Okay, well, last question before we take a short break. You talked about North Manchester General Hospital being rebuilt as a net zero carbon hospital. Does the same apply to all the other developments in the city of Manchester? There's lots of high-rise building going on in Manchester.
Yeah, that is actually the aim, that any new building that's built goes through the carbon filter, as we call it, and that is absolutely the commitment. I don't know the exact details about all new buildings are going through that, but that is exactly the commitment that we have. You know, I can try and get back to you on that with regards to whether all new buildings are going through that, but my understanding that is.
Okay, well, thank you very much, Raja. That's fantastic. There are some more questions in the Q&A box, which perhaps you can put some typewritten answers in if you've got time, and we'll have a look at those. So we're going to take a short break now, and then we'll come back at 3:30 and start the next session. So thank you very much for attending so far. Keep on thinking what you can do to address the issue of climate change, and we'll see you after a short break. Thank you. Hi, I wonder if Fiona could turn my camera on. I think my video's been stopped by the host. So there we go. So, gosh, I'm back there. Well, I hope you all managed to have a successful break. And I've launched the next poll, which relates to our next speaker's talk. So if you go to Slido 2653, there's a question about reducing waste. And it's an enormous pleasure to welcome my colleague, Claire Igo, who's the head of sustainability in Manchester University Foundation Trust. And Claire is responsible for leading the agenda across a large group of hospitals. There's a lot of us in MFT. And she's got a lot of experience in environmental studies and sciences. And for the last 2 years, Claire has been co-leading the sustainability agenda across the Greater Manchester Health and Social Care Partnership. When I first developed the idea for the concept for this symposium, I started to ask questions about the waste that we were producing in theatre, and I'm never really sure exactly what happens to it. And so it's over to Claire, who's going to take us on a healthcare waste journey and tell us what really happens to all those things that we throw away and then perhaps don't think as much about as we should. So Claire, thank you for joining us today.
Thank you, David.
And over to you.
Yeah, thank you, David. Can you see my slides okay? Hopefully. You'll tell me if you can't. So just looking at the Slido poll, I can see that the 86% answered all of the above, and then we've got some other answers in the other boxes. So we're going to talk about that as we go through. I think the answer is all of them are important, but it's about which ones do you pick in particular scenarios. So David asked me to come and speak to you all about healthcare waste and what happens after it goes in the bin. So my role is wider than waste management. I've been in the NHS since 2013, but I have had responsibility for waste management since all but the first 12 months of that. So hopefully I'm in a reasonable position to be able to talk to you about that. And as David said, I work for MFT, as do a couple of other colleagues on this call. We're a really large acute trust with 10 sites. So I kind of think if we haven't seen it at MFT, then we probably haven't seen it anywhere else. But I'm not going to just go on to my first slide here. So you'll probably be slightly relieved to hear I'm not going to talk about waste compliance today, because that is a whole session on its own. I'm going to focus more on giving you an introduction to what happens to healthcare waste. There is some complementary pieces in terms of particularly what Chantal was talking about earlier. So I'll talk to you about how waste is managed at a hospital. I will focus more about a hospital environment, but most of the principles we'll talk about would apply to any type of healthcare environment. And then I hope that I'll help you to look at waste in a different way. And again, this will follow on from some of the discussions we had earlier. I'm going to talk a little bit about plastics as well in the NHS and recycling. First of all, in a healthcare environment, there are many different types of waste. And again, I'm not going to talk about all of them right now. Did a count up a number of years back, and I think we got to something like 27 different waste streams, but most staff on a day-to-day basis won't encounter all of those. So this is a flow chart that we developed at MFT to help inform staff about the waste streams that they're most likely to encounter. Each type of waste is given a set colour code, and then the decision about where to put that waste, it's a risk-based approach, and it's also about what that waste is contaminated as opposed to necessarily what that waste is. So the main ones on here that I'd just draw your attention to would be the orange or infectious waste stream, and then the one at the bottom, which is known as offensive waste or tiger waste, and that's colour coded yellow and black striped. So it's just worth pointing out here, because I will be talking about what happens to waste. It does look in the NHS like we incinerate a lot of waste, but it's actually only really quite a small proportion of that does have to be incinerated by the law due to its properties. But something like infectious waste, I think it is perceived that it has to be incinerated. It doesn't. It has to go for some heat treatment to remove the infection, and then it goes into a flock. So this I've taken from some national NHS guidance, and there is a waste strategy for the NHS that is due to be published. I'm not exactly sure when this year. I think maybe spring, or possibly that might be delayed, but there is a waste strategy coming out. But the NHS as a whole does produce around 600,000 tonnes of waste every year, and that's about 1% of all of the UK waste, and around 133,000 tonnes of that waste is plastic. So when the waste strategy comes out, I think we'll get more of an up-to-date idea on what the NHS is spending on waste at the moment, but there's a figure there to give you an idea that was £87 million on waste disposal. And I think Chantal's already made this point that when you look at waste in terms of either carbon or cost or anything, you're really only looking at a fraction of the true cost there. Once you think about the raw materials that have gone into that product, and energy, water, labour, storage and transport, it's actually only a fraction of the true cost and the true impact. So this shows you at MFT, the organisation that I work for, what would our waste look like in terms of where does it go. So this was from 1920, and in that year we produced 6,825 tonnes of waste. 17% of that was recycled, and that includes food waste that goes to anaerobic digestion. We landfilled 4%, 11% of that was incinerated with no energy recovery, and that was the waste that I mentioned before. That's the bit of waste that has to be incinerated because of its physical and chemical and hazardous properties. And then we had 67% of that waste that is converted into energy by incineration. And that is waste that perhaps in the past would have ended up in landfill, but there is a move away from landfill now, and energy from waste is preferred as a disposal approach. So I've taken this, we're currently in the process of getting this updated, and unfortunately I couldn't get the up-to-date copy for you in time. So I think just maybe the costs aren't completely up to date here, but I thought it was really useful to show in terms of just giving you a general idea about what stream you put your waste in and what impact that has. So, for example, if you were to put some clean packaging into an infectious waste stream, that would then go for alternative treatments. That would go for heat treatment, and then it would go for energy from waste. So as well as the increased carbon impact from the heat treatment of that waste will be costing, and I think the figure will be higher than that now, but at least double what that would have costed if it had gone into the correct waste stream, which in that case for some clean packaging would most likely be general domestic waste. So I've taken this diagram from the NHS net zero carbon strategy that was also mentioned earlier, and I think following on from what Chantal said, if you look at waste purely in terms of carbon, it is purely a fraction, and in this report it made up that if you look on the left hand side there, that 5% from water and waste, so quite a small fraction in terms of waste, but it is still important, and we need to think about other issues such as resource scarcity when we're thinking about waste management in an environmental management perspective. So hopefully most of you will be familiar with this, but I couldn't do a talk about waste without mentioning the waste hierarchy. So what it is it's a set of principles for managing waste, which is ranked according to the environmental impact. So the preferred option would be to prevent or reduce that waste, and the least preferred option from all of those would be landfill. And I think the reason for showing that, and I'll come back to this a little bit later on, is that we do find a lot of people jump in at recycling when they're thinking about how to reduce waste, but what we really need to be doing is thinking about how not to generate it in the first place, or how to reuse that item and keep it in use, so it doesn't end up going to waste. So within a hospital environment, there is a team of staff that are employed to manage waste, and so you will have domestics and housekeepers, and in some cases ward staff as well, that will take waste from a ward environment or a theatre environment and move that to a waste hold. Then there are waste porters that take that waste from a hold and move it to a waste yard. And then from the yard, waste contractors will come and collect the waste from that yard, and they will generally, if you think about the healthcare waste as opposed to general domestic waste, they will bring clean bins to site and take away full bins, and so on really, which then get delivered to ward level. Some sites will also have transport drivers that need to move waste around the site depending on the size of the campus. You've got all those people that play a vital role in keeping the hospital clean and safe and making sure that the hospital is compliant with waste management legislation. Then you'll also have convention staff there. You'll have waste managers and waste officers as well, depending on the size of the organisation. So waste can often be a hidden function within a hospital, and I think little is thought about that waste when it actually goes in the bin and what happens after that. But I just wanted to show how hard our waste officers have to work at times. So during the COVID pandemic, things have been quite challenging in terms of getting the waste collected and removed from site. So there has been disruption at times to collections. So this is what happens if the waste contractor doesn't turn up on one occasion to collect the waste, we have to end up decanting that waste into a shipping container. On this example, and this was only from probably about a month ago, I think, that this picture was taken. So that waste did, of course, get removed after a few days, but there's a lot of people working really hard behind the scenes in a hospital environment to make sure that that kind of disruption is not felt elsewhere throughout the organisation. So unusual waste. So we produce training for staff, we produce guidance, but you can produce all the guidance you like, but from time to time there are unusual waste streams or things that we get asked about that we weren't expecting. And I've just pulled out a couple of examples of those. I'm not going to go through all of those now. So a few years ago, we were in the middle of a very hot summer, and we got a call from one of the waste porters to say that they'd had a call from a member of staff on a ward about a patient who'd had a recent amputation and had decided that they would like their leg back so that that leg could undergo a full burial. Without going into details, that was for religious reasons that patient made that request. So not something we come across before, but what the porters did was they did their best to locate that leg, and they eventually found it in one of the anatomical waste bins. So this was after quite a number of hours in very hot temperatures, and I don't really want to think about what condition that leg would have been in. But anyway, in the meantime, the ward staff had arranged for the patient to have some religious counselling, and we were relieved to hear that the patient had decided that they didn't want their leg back, and that leg went off with the normal. Just to be clear here, we would not have handed the leg to the patient. It would have gone to an appropriately authorised company to take that for burial, but we actually they actually changed their mind then, and we disposed of that leg in accordance with normal procedures. Another one I wanted to mention was leeches. That's quite an interesting one as well in terms of a waste stream, not a major one, of course, but a leech has a function to perform, and then they can't, once they've been used, they can't be used on another patient. So that leech would be, after a use, it would be put into alcohol and then it would be incinerated. So effectively that would be treated as a contaminated biohazard, even when it's being used on a patient that hasn't got any infection. So it has been suggested by one of my colleagues that we could actually have a leech sanctuary for these leeches that have done a really good job, and then we're incinerating them. So to bring to life a bit more what happens, and this also came up a little bit earlier on, to bring to life what happens in terms of waste, I've pulled this out in terms of a pair of single-use scissors and what would happen. I have simplified the supply chain a little here, but hopefully you'll get the general gist of it. So the scissors have been manufactured by Qatar Steel, which is over 4,000 miles away, as shown on this map. These are single-use scissors. And then the single-use scissors are shipped to the UK, and that would normally, that would definitely normally be shipped rather than air freighted to the UK. So once they arrive in the UK, they would then be transported by lorry to one of the NHS supply chain distribution centres, and then from the distribution centre, they would then be distributed onwards to the hospital. So the scissors are then used by a department. This isn't a real example, but let's assume that those single-use scissors were used in an outpatient's fracture clinic at the Children's Hospital. So the scissors would be used once, then they would be disposed of in, let's say that they're put in an orange lidded sharps bin in this instance. So thinking about where that sharps waste would then go, sharps waste would need to be incinerated. So from the hospital where I work, that would typically go to the incinerator in Oldham. The infection, so it would go to the incinerator. The incinerator will destroy the infection if there was one in those scissors, and we can question over whether or not they should have gone in the infectious waste bin, but it won't destroy the steel. So that landfill ash with scissors in it will potentially end up in landfill. So what could we have thought about here? So potentially reusable scissors could have been used, and they could have been sterilised on site and returned. I think as was covered earlier, reusable isn't always the best option in terms of carbon footprint, but it would certainly need looking at in this instance. And then if it was decided that reusable wasn't feasible, there are the waste companies can provide receptacles for single-use metal instruments, and then they could have gone off-site and been reprocessed. And I think after what Chantal was talking about earlier, I'm not aware that repair is very common, but it's certainly something that I will be going away and looking at in a bit more detail. So thank you for that. But again, there's all sorts of things we could have thought about here if we'd have said, well, why are we using single use, and what are the other options? So potentially on that point as well, if something like a waste stream like that is quite valuable and maybe would have even generated a small income, particularly in an environment where you've got a lot of an item being generated in a small area, then you're not sort of cancelling out the benefit of the recycling by the amount of logistics that you'd have to put in place to move and pick up that waste from around the hospital. So I think certainly in that instance, I would be looking into those options. So I wanted to move on and just talk a little bit about plastic. So plastics are a material of concern for lots of reasons, but they also have lots of properties which make them really attractive. And that's why they're in widespread use. We know that plastic will preserve and protect items, it's lightweight and it's versatile. But what has happened over the past decade or so is that there's been this huge increase in what you could call maybe on-the-go plastics and single-use plastics. So many of those are only used for minutes before they're disposed of. So we've got other concerns as well, like microplastics in the environment. And according to this statistic, over 90% of seabirds have plastic in their stomach. So there's quite a lot of challenges with plastic recycling because there are so many different types of plastics. It's quite challenging to recycle. So if you're creating a mixed plastics waste stream, that's not very attractive. Whereas if you've got a lot of one particular type of plastic, then it may be then more viable to look at that. But certainly in terms of biodegrading, I just picked out bags for as one example here, because a bag would be used for a shopping bag here where you'd use it for 15 minutes, but then that would take 10 to 20 years to degrade. So I just wanted to challenge your thoughts there really around plastics, and just thinking about the fact that there's a statistic there that only 9% of all plastic ever produced, of all virgin plastic ever produced, has been recycled. So in terms of plastic in the NHS, the percentage of plastic waste in NHS streams is significantly higher than other industries, and it may be that there is some more up-to-date data available, but at this time when this piece of work was done, single-use theatre protective clothing and examination gloves were the highest by weight, and this was well pre-pandemic, so I would imagine that would be an awful lot higher now. Let's look at that again. I think this is similar to the example that Chantal had earlier on as well, but this picture was taken at a Devon Trust, and this was from a single cataract operation. So the person laid out all of the items that they used during that operation, weighed them. You got 2 kilograms of waste there, of which 1.3 kilograms is plastic. And when you start to multiply that up in terms of the number of cataract operations, the number of other operations, then you can see where that huge volume of plastics within the NHS waste stream comes from. So I'm not going to talk about PPE today in any detail at all, but we all know that COVID-19 has led to a rapid and significant increase in demand for PPE. So it's something that we've been looking at with our Greater Manchester partners, and I know that there's much other work going on across the UK to look at how we can reduce the environmental impact of PPE. But in Greater Manchester, for a 6-month period last year, there were more than 56 million individual items of PPE ordered by Greater Manchester providers, and over 90% of those were imported from Malaysia and China. So what can be done to reduce plastics in healthcare then? As I said, I think it's important, and we've said this already, is everything needs to be looked at on a case-by-case basis, and it can't always be assumed that something like going to reusables is always appropriate and is always lowest in terms of carbon footprint. But I've pulled off a couple of examples here. So we've got an example here of switching from single-use urethral catheters to reusable. And that could be calculated if that was scaled up across the system, that could save around £200 million. And then another project, we've been doing this at MFT for probably around 3 to 4 years now. It's called RecoMed, and they're interested in PVC waste, and they will collect things like PVC face masks from a theatre environment, and then they can be recycled and turned into new low spec products. And that's an example of, I think, collecting something in a quite controlled area where you're producing a high volume of those. So recycling, I wanted to briefly cover recycling, because I think recycling it can take the guilt out of using a product, but potentially it promotes additional consumption and a clean conscience. So I think much of what we think we're recycling, we're actually not recycling. So the UK itself does not have sufficient infrastructure for recycling, and we don't really know when you start to look down the supply chain. So much of our plastic for recycling is shipped to countries that will accept it, and some of those countries do not have high environmental standards. If batches of recycled waste are contaminated, then they won't go for recycling either. So there is, I think, somebody had posted a question earlier. So there is a waste and resources strategy that the government released in 2018, and there are various initiatives coming in to tackle things like plastics and recycling. So there's an extended producer responsibility, deposit return schemes, and things like requirements for minimum recycled content in products. And that I'm very supportive of is shifting the responsibility back to the producers of those items to think about them across the entire value chain. And I think certainly that is something that we need to be challenging the NHS supply chain on as well. And I'm working with some colleagues in Greater Manchester and beyond to start having some of those conversations. So in terms of, so just to go on recycling then, it has a place. I'm not demonising recycling at all, but it does work better in certain controlled environments, but it shouldn't be the first thing that you go to. So what can you do then in your roles? So most trusts and organisations will offer some form of waste training, or you can potentially access that through your professional body. One of the things that we find is putting the bins in the right place. Sounds really simple, but it actually really works. So much contamination happens when bins aren't in the right place. I'll show you that picture on the right hand side there. Is we often joke about the infectious Jaffa cakes. Something's gone wrong there. I would be pretty certain that packet of Jaffa cakes is not infectious, so it shouldn't have ended up in the orange bag waste streams. So challenge that locally if something doesn't look right. And I've, again, suggesting improvements as well, and there's a few stakeholders there that you may wish to talk to when you've got ideas around improvements. Segregate your waste properly. It takes a fraction of a second to read a label and think about where you're putting something, but over time that does become a habit and doesn't need the extra. And then when you start to scale that up across organisations, that has huge environmental and cost benefits. And then I think always just looking for opportunities to change your own area of work. I mean, in my team that I manage, we really like it when we've got members of staff coming to us and they've got an idea, they want to do something and they just want a bit of reassurance or a bit of hand holding, or just maybe even just some promotion of the thing that they're doing. So we're always happy to support that, and I'm sure you've got similar teams within your own organisations. Thank you for listening. That's the end of my slides, so I'm going to stop sharing, and I think we've got a couple of minutes. I haven't been able to see the chat as I've gone along actually, so maybe David, you could
yeah, no, absolutely. No, that was fascinating, Claire. and there's one question which is technical about the carbon footprint of recycling. So we're recovering energy from waste, but
yes,
we're also burning it to create the energy. So is there a net reduction in carbon? What's the carbon footprint balance of recycling and generating energy?
Right, so I don't have the carbon factors in my head. So the waste hierarchy that I showed you before, as you move up that, so as you go up from landfill to energy from waste, and you go up, the carbon factor changes. But perhaps I'll have to answer that one offline when I've got the figures in front of me, unless Chantal's still on. I don't know whether Chantal.
So does that generate greenhouse gases?
Yeah, right. I can just answer that if that's helpful.
Thank you.
So when we think about, so I think the question is between recycling items versus getting energy from waste through burning those items, and so you're still in that instance using incineration, high temperature incineration. You're then offsetting that with the generation of electricity, as well as you're able to get the scrap metal, but the carbon footprint is still then a lot higher than recycling. In terms of the actual carbon footprint of this recycling itself, it depends on whether we're assigning the carbon footprint of the recycling process to the user of that product or the person who generates the waste. But essentially, we can't absolve ourselves of responsibility just for putting something into a waste stream where there's energy from waste. Certainly, the recycling schemes are going to have a much lower carbon footprint. If you're interested in the actual figures, then there's a publication in the Journal of Cleaner Production, and that was released just a few weeks ago. And I'll put that in one of the chats so that people have got access to that.
Thank you.
There is a question about putting waste in the wrong bags. And I don't know, is that something we just tolerate? But also one of our colleagues is asking a question talking about having the wrong bag. And I took a picture of what I thought was the wrong bag, which was 2 orange bags next to each other, when in fact it was in a room with a patient because of their infection risk. They couldn't have an ordinary recycling bag. So do we do anything to feed back to staff?
So we do have a programme of regular waste audits across the organisation. So we may pick things like that up during a waste audit, but bearing in mind we can't be everywhere at once. So that's about having eyes and ears on the ground. And I think, David, in that circumstance that you mentioned, absolutely right to challenge it. Sometimes there's a valid reason, but what we found during the pandemic is there's been huge pressure on facilities that can accept infectious waste. And then we've also got staff taking a very risk-averse approach and putting lots of things into the infectious waste stream or changing bags out unnecessarily. So it's actually been really quite challenging to keep on top of that. So where we do come across that, I'd say always ask locally in that situation. But so in some cases there will be a good reason, but in many cases it's just this perception of risk that isn't there, and then what that does is then cause problems across the whole system.
And someone who must be in the know has said that Recomed have currently got a very long waiting list.
Yes, I think for new clients they have.
COVID, is it?
No, I think that's been a while now that they've had. Yeah, so there is a waiting list. Again, that's just one example, but no, I don't think they're accepting. But again, it's probably still worth registering your interest, and then if you were interested, and then I'm sure they'll start accepting new customers soon for that scheme.
I know Chantel's asked if we can share the link to her carbon footprint paper, which I'll try and do at some stage. But that's fantastic, Claire.
Yeah,
that's very informative. There are still some questions in the Q&A box, which we'll see if we can answer.
Okay.
But we'll move on to our next speakers. And I've not had time to WhatsApp Cliff and Rebecca to tell them that I've got the Slido ready to share when they want it. But it's a great pleasure to introduce 2 of my colleagues from MFT, Cliff Shelton and Rebecca Sutton, who've been very active in a practical sense in addressing the sustainability agenda. And Cliff is a consultant anaesthetist in Wythenshawe Hospital. He's also a senior clinical lecturer in anaesthesia in Lancaster Medical School, and he's been involved in teaching environmental sustainability. And we're also working together on the James Lind Alliance priority setting partnership. And Rebecca's a consultant paediatric anaesthetist at the Children's Hospital in MFT, and she's somebody else who's been very proactive actually in the workplace in addressing the sustainability agenda. And I think we were able to be joined by 2 of our anaesthetic fellows who are involved with our sustainability initiative, Rishi and Max. So it's over to you, Cliff, and I'll go straight to Slido. And the Slido number I think you've got.
Thank you. Can you all hear us okay? Look at the WhatsApp. And we'll go with a yes. So thanks for that nice introduction.
Perfect.
David.
Can hear you.
Thank you very much. So thanks ever so much, everybody, for some brilliant talks so far. I think Chantel's told us sort of where we need to be heading, and Murugesan's given us some really good strategic overview. Claire's given us an excellent appraisal of what happens if you throw something away that maybe doesn't need to be thrown away. But what I think brings all of these things together is there needs to be some way of changing behaviour, and that's really what Rebecca and I are here to talk to you about. So we want to share some stories about some of our things that we've managed to change eventually, and maybe reassure you that it's not always straightforward, and give you some tips about how you might make positive changes in your workplace. Because this picture you can see on the screen here kind of represents where we are now, which, as Chantel summed up, is arguably not in a great place from a sustainability point of view, and with a big backlog of work still to be done once the pandemic starts to subside. So I think we do need to do things. We need to take action urgently, but we're going to face some challenges over the coming months and years. So as David said, we're going to try to interact with you a little bit. Going to try to use the Slido system, and it's great that we've already used that. But if you're a late joiner, just so that you know and you're not left behind, if you can go to www.sly.do and then enter this code just here, 2653, in the participant box as listed on the screen there. So if you can interact with us, that would be absolutely great.
So you've heard a little bit about us. So our first Slido question and our little practice to check that we can make it work is, could you please answer the following question? What is your professional background? So the poll should appear on your alternative device now. If you could answer that question.
And David, you should be able to share the Slido master screen from your computer.
And we have lots of consultants. Ooh. I think maybe we'll have to do a look at on our devices rather than.
Oh, here we go.
Ah, perfecto. So overwhelmingly consultants, 13% other, which is interesting, right? And GP specialty doctors and trainees. Very few allied specialties.
Okay, so that's absolutely brilliant. Lots of senior colleagues and lots of interested others as well. Really great to have you here. Let's move on to the next question, which is that we'd like to know a little bit more about your background. So we know kind of what your professional grade is, if you like, but we'd like you to type in what field or specialty you work in. So for me, that might be anaesthesia, for instance, and this should generate a little word cloud, give us a clue about who we've got at in the virtual seminar.
Oh, I like this.
A lot of anaesthetists.
A lot of anaesthetists.
Well, you know, we've famously got a guilty conscience about this, so hopefully we're all here to move things in the right direction.
Oh, that's a really nice little cloud. I like that. So obviously, hello, fellow anaesthetists, but welcome all. This is really great. Constantly updating. Okay, so our next Slido question, we'll just leave that word cloud there for a second maybe, but the next Slido question is, I want you to think about the challenges you faced when you've tried to implement sustainable healthcare practices in your workplace. So we've both been trying to do this for quite some time now. We know it's difficult. We've got plenty of challenges that we can share, but we're really interested in your experiences. So so go. Oh, time. Yeah, nice. Okay, ignorance. Nice. So this is more difficult to read, right? Because they keep spooling up quite quickly. Ah, okay. Yeah, lots of things that we'd blockers, lots of things that we'd identified, but some some other interesting ones as well. So I'm seeing changing people's behaviors, being blocked, lack of interest, resistance, not putting waste in the right bags. Yep. Attitudes, interest, and just the lack of time. And particularly now, I think in the midst of this crisis, it's really difficult to persuade people that sustainability is something that they should be devoting any of their headspace to. Anything else you want to say about that, Cliff?
No, but this is all good stuff, because hopefully what we're going to talk about as we go through the next 20 minutes or so is some of the ways that you can get sustainable practices into your workplace whilst accommodating some of these concerns around the need to prioritize other things perhaps, and things like financial and time considerations. So David, if we could have control of the screen back, that would be absolutely great.
You should have that, Al. I've stopped sharing.
Yeah. Lovely, thank you. So, so this is probably a familiar graph to most of you. This was a business model that was devised by Everett Rogers in 1962, and it was essentially to show the market adoption of a new innovation. But it's been discussed and repeated and applied to all sorts of things, and we think it's quite a nice framework for hanging off our sort of behaviour change around sustainability. So. What I was going to say about this. So I think we would like to assume that because you're here and listening to us, you are among the innovators and early adopters, and they are, I shall stroke all of our egos for a moment, they are people, bright people with a lot of social capital who can recognize an idea that has merit and pursue it and support it. So so well done you. But we do know, I'm going to click to my next slide now, this model has been refined, and I particularly like the curve that's put on top of it on this slide here. This is called the hype cycle, and again, it was devised to talk about business innovations, but I sort of think it has a bit of an emotional and sort of effort type trajectory to it, and I really like the language of it. So I think we can all recognize this this big peak where you feel like you've got an idea and you think everyone should share your enthusiasm about the idea, and you can't see any possible reason for everyone not adopting your idea, and then you get a bit of pushback. People find obstacles, or what was the word, the blockers and the naysayers, and then you descend into the trough of disillusionment, or as Rogers had it, the chasm of the early adopters. And the other thing that I like about this, the other thing that I think it helps us to recognize, is that this is a really energy and effort intensive process, not energy in a carbon sense, energy in a personal sense. So it's really hard work to make a case and to take people along with you. And so it can feel sort of quite isolating, and as if you're not really getting anywhere in those early stages. That's the next bit. The other bit, and we'll maybe come on to this a bit later, the other bit that takes a lot of effort is to persuade those last few percentage of people, the laggards, as Rogers had it, to go along with you on your innovation and your behaviour change. And we'll maybe come back to that a little bit later.
So I think this model, whilst it probably doesn't have a great deal of evidence in this particular setting, reflects a lot of those challenges that you guys were kind enough to share with us. And what we'd like you to do now, again, if David, you could share the Slido screen, is for those of you who have managed to effect a positive change in your workplace, tell us a little bit about how you managed to do that. So we've asked you to please describe the solutions or successes that have helped you to implement sustainable healthcare practices in your workplace. And what we'd really like you to talk about there, in just a few words if you can, is the way in which you achieve things. So it's great if you can say what you've achieved, but what we're really interested in is the how, the strategies that you implemented to get people over the line and bring people with you. So let's get Slido back on again. And I'll just boot it up on my phone. Okay. So this is an excellent.
We should all
strategy.
retire. Brilliant. Teaching trainees good habits. I'm delighted you've said that. We shall touch on that in a moment.
So we've got some really interesting things coming up there. So I like this thing about gentle persistence. I think that's a really neat phrase. And I think, the gentleness is important. We'll talk about that later on as well. But I feel that my experience would suggest that people don't like to be beaten around the head and shamed here. They like to be brought along with you. We've had here some stuff about desflurane. That's going to be my worked example later on, so we'll pick up on that. Quite a lot of sort of collaborative noises being made here, wide consultation, taking people with you, and repetition until familiar. I think that's quite important too.
Somebody's managed to get metal recycling up and running. Well done, you.
Absolutely. Please email the attendees and let us all know how you managed to do that, because that's fantastic. All right, I'm just going to wait a couple more seconds, make sure that anybody who is frantically typing to try to get their point across does get heard, and then we're going to stop sharing and move on in just a sec.
Getting the right
people. And we'll capture them all for later.
Yeah, great.
Okay, so we've got here, get top people on board, get a named person and set up the unit, identify good examples from elsewhere in the healthcare system and build into everyday action. I'm glad that's in there, because I think what that suggests is that there's definitely two angles to take to this. And one of them is the kind of top stuff. And I guess that's to an extent what Dr. Raja was talking about, having a regional or an institutional strategy, and what also Claire and Chantel have come across. But there's also a sort of importance of a bottom-up approach. Bringing those people at the coalface along with you is also really important as well. So thank you for that, David. If you can give us the screen back again, we'll talk a little bit about how we can get this to work in practice.
You should have it.
We've got it. There we go. This is the highest risk technology presentation I've ever done, but it seems to be going okay so far. So we've seen this before, the triple bottom line. Chantel was kind enough to share this. And I want to go through a kind of worked example of how this might be used in terms of achieving some behavioural change. So Chantel's already summarised it. We use slightly different words, but I think in the NHS context, social can be taken to mean the treatment of your patients, as well as your responsibility for the broader society. Environment is the reason why we're here, and economic, I think we all know quite a bit about already. And I tend to use this as a framework through which to approach potential candidates for things that you might be able to change in practice. So, for example, we're all attending this workshop because we're interested in making the environment better. But I think we need to be accepting of the fact that as healthcare professionals, most of us, I think it was were from a medical background when we did our little poll at the start. We do have an ultimate responsibility to our patients. And so I think as a general rule of thumb, you want to make patient care ideally better, but really try to avoid making it any worse. And I think, certainly some of the debates around minimally invasive versus, maximally invasive surgery could sort of stumble on that particular criteria, but it's an interesting way to look at things. And then from an economic point of view, I think you might be able to justify costs if you can make a really strong argument on the other two bases. But picking something that's ruinously expensive from the get-go might not win you many friends in the first instance. So this is a really good practical screening tool for looking at things where change is achievable. I think as we move towards that 2040 goal of being carbon neutral, changes are going to be harder, and some of these criteria might have to become modified. But at the moment, there's plenty of things that you can find if you look around that tick these three boxes. So I would suggest that this is a good sort of screening tool for getting behavioural change underway. So I'm going to use desflurane as a worked example, and lots of you are anaesthetists, but to give you a sort of potted, sort of summary of desflurane and what it is and why it's a problem for those of you who don't work in theatres, it's one of the volatile drugs that we use to keep people asleep in the operating theatre. And on the left-hand side of this graph, you can see a sort of diagram of why anaesthetic vapours can be a unique problem. So not only do you have to expend some resources in producing them and delivering them, but when they're breathed out by the patient and released into the environment, they trap and then re-emit solar radiation, which those of you who work in anaesthesia will know is also the way that we detect them as they come out of the patient. That's how we monitor their presence and make sure that the patient's having enough to stay asleep. But different volatile agents, although they do just about the same thing in terms of keeping the patient unaware of their surgery, have varying effects on the environment. And one way of summarizing this is to use the concept of a carbon dioxide equivalent. So what this means is that if you release a kilogram of, say, sevoflurane into the atmosphere, that's a bit like releasing 49 kilograms of sevoflurane into the atmosphere over a certain time horizon. Now, it's not a perfect measure, it's got some criticisms, but it's a reasonable rule of thumb when comparing these things. And you can see that desflurane is, just about an order of magnitude worse as a substance than sevoflurane. And then when you take into account that you actually need to give the patient about 4 times as much of it to keep them asleep, then it's kind of 2 orders of magnitude worse from an environmental perspective. So desflurane is sort of become the poster child of anesthetic emissions mitigation, because a lot of people think that it's something that we can live without, and it's something that has fairly marked environmental effects. So the other thing that's nice about desflurane is that unlike a lot of the very complex systems that we encounter in healthcare, it's something that me as an anaesthetist, or Rebecca, or any of us could make the individual decision not to use. So I think it's a choice that we are privileged to be able to access, and therefore is really amenable to the sorts of behavioural change that doesn't create or doesn't require an insurmountable amount of effort at a difficult time like this. So looking through this triple bottom line lens at desflurane, we can kind of run it through the process, and we can see, well, how does it stack up? So it's, first of all, it's more expensive, so you need to use more of it, and there's also some increased costs in its delivery. The clinical benefits I'll talk about a bit more in a few minutes, but they are, let's say, uncertain at best when compared to other inhaled anaesthetics. And as we've just talked about, it's much less green. So through this triple bottom line lens, this is a very low hanging piece of fruit that I think is really amenable to change. Which raises the question, well, why on earth is it still used? So Rebecca and I have actually written a paper on this together with our colleague from Brighton, Stuart White. And we were sort of scratching our heads about it and did a literature review. And here are some things that we think are potential candidates. So one thing is that patients wake up a few minutes quicker versus sevoflurane. And we've actually summarized what the evidence from various studies is on this. And you can see here that at best, you're going to get the patient to open their eyes just about 4 minutes earlier if you're going to use desflurane. In terms of when you can actually get their tube or their laryngeal mask out, again, if they're obese, that's the sort of second, third from the top study, you might have a 4-minute benefit. But actually, when it comes to discharging them back to the ward, so, a patient-centered outcome, when the patient's back to being okay to look after themselves, at best, there's no significant difference. So arguably, this benefit might affect the anaesthetist, but probably doesn't affect the patient or the broader operating theatre team. There are also some assumptions about clinical benefit. So, for example, is it a good thing to have people open their eyes a bit quicker, or the anaesthetic to wear off a bit sooner? And that's really appealing from a sort of gut feeling basis. But actually, there's been some really helpful observational studies recently with thousands and thousands of patients, which don't suggest that there's any benefit, for example, for respiratory patients. But what I think is probably really important is the sort of inertia of habit and institutional culture. And I think if you get you establish your practice at an early stage, say as a trainee, it's quite hard to change your practice, especially as an anaesthetist, where you don't necessarily work in teams with your colleagues and get a sense of, what is the consensus in my department. So at Wythenshawe Hospital, where I worked, we've not banned or forbidden desflurane, but we've taken some really important steps towards getting rid of it. And thinking about how we achieved that, I think there's these 4 important steps. So the one that's hardest to actually capture, I think, is that for us, there was a sustained program of background work, sort of talking about this on a fairly subtle and interpersonal level, and not really with a great deal of strategy behind it at the start, but more a sense of interest amongst colleagues. Then there was an attempt that we made to illustrate its environmental harms and suggest that maybe we should stop using it. But actually, that was not found to be compelling enough on its own for us to make any changes to our institutional policy. What actually did get us over the line, though, was an audit of anaesthetic technique. As I said, it's quite hard to get a sense for what your colleagues do as an anaesthetist. And it was demonstrated through that most colleagues don't even use inhalational anaesthesia, never mind there's fluorane. And that allowed us to build a consensus at the departmental meeting, not to ban it or forgive it or forbid it, but to take it off the anaesthetic machines and stick it in the cupboard. So what we've really done there is made a sort of behavioural nudge to just make it slightly less convenient to use. And although it's hard in the context of a pandemic to say whether we've made a big impact on practice, anecdotally, we're using it a lot less than we were. And mapping that onto Rebecca's graph, I think the sustained background work probably got us over the hump of this curve before we actually tried to do anything formal.
This just to that point, there's something really really useful and helpful about demonstrating what the majority of people do. I think there's been a lot of talk about that, hasn't there? The psychology of over the pandemic of normalizing adherence to rules, and I think much as we like to think we're free spirits, knowing what other people do is a really powerful motivator, I think. So we're going to talk a little bit more about education, partly because it's in our title, but it's in our title because we are both convinced of the importance of it in terms of forwarding the sustainability agenda. So if we go back to my double graph here, the highlighted yellow area is where we think a lot of the effort and heartache, if you like, goes in to getting new ideas and new behaviours to really take off. So we think that if we put this the effort into educating the next generation of practitioners, what we really want to do is graduate people who are basically innovators, early adopters, and we want to graduate them into an environment where behaviors, green, sustainable behaviors, are more normalized. So yeah, putting the effort into the education to perpetuate sustainable behaviors. And in a phrase that Cliff said, what we really don't want to be doing is graduating laggards. And the way, how do we achieve this? So in some ways, this is being done for us, in that various very high-level organisations have recognised that their curricula need to reflect the need for sustainability in education. So the GMC, the College of Midwifery, Nursing and Midwifery, and the Royal College of Anaesthetists have all either got sustainability strands in their curriculum, or are proposing to do so imminently. So you might think that sustainability in education is not something that you necessarily need to know about or worry about. But if you come into contact with any of these groups of students, undergraduates or postgraduates, sustainability is going to be a significant strand throughout their education. And I think, coming back to the triple bottom line diagram, I think this is a really nice way of integrating this into your teaching and training. So so what we think we know is that people don't really like being bashed over the head with sustainability as a single topic. What students have fed back that they like and enjoy and appreciate is to have sustainability woven through clinical scenarios. What was Chantel's phrase? To view things through green lenses, really. So, you know, we're used to talking about the social, the impact of what we do on our patients, and we may encompass a little bit of the economic, but what students have fed back that they'd like us to do is to pretty much center it over those three issues, and incorporate sustainability in our explanation and justification of our choices for our patients, if that makes sense. So to that end, clearly we think it's important to weave sustainability throughout our teaching, but we also felt that it was useful to demonstrate that this is a specialism and to give it some standing and some kudos in our field. So the School of Anaesthesia in the Northwest have created a sustainable fellowship post, and we've got the two current incumbents to just tell you for a few minutes what they've been up to. So we are going to attempt to swap over now to Max and Hrishi. What could possibly go wrong?
Hey,
Hello.
Hrishi.
Hi, hello everyone.
Hi, it's Max Clayton-Smith. I'm just going to share my screen. Is that all right for the slides? Great, lovely. So, fine. So, hi, my name's Max Clayton-Smith. I'm one of the Anaesthetic Sustainability Fellows, along with Hrishi. We're both ST6s in the Northwestern School of Anaesthesia. And so we've spent this year spending half our clinical time doing sustainability fellowships. Some of that time is going to be spent with Cliff, David, and the James Lind Alliance, which we'll talk about in a second. But meanwhile, what I've been up to this year, so really just a couple of projects within MFT. So me personally, talking back about the triple bottom line, I mean, I'd love to say that I've invented some sort of solution that dissolves packaging to power my e-bike on the way home, but it's been a bit more sort of mundane than that. There's been a lot of talk, like Cliff mentioned, about desflurane and reducing that, which I think really has focused anaesthetists on this sort of environmental impact because it is so adverse. But really, the first part of what I've been doing in MFT is trying to talk about, is general anaesthesia actually needed at all? There are various techniques for anaesthesia, particularly spinal or neuraxial blockade, where any surgery sort of below the umbilicus really is a candidate for potential spinal injection. And then something that requires slightly more training is regional anaesthesia, so injections into individual nerves that numb the area required, leaving the patient awake. And these in themselves are fundamentally a lot more, in terms of CO2 equivalent, a lot greener than those. And the thing is, they're already kind of established practice. So really, you know, through trip and bottom line, they're cheap, they're green. We just kind of need to persuade people to do more of them. And I'm spending some time, I've written a pathway for one type of spinal anaesthesia. And I'm spending some time doing surveys of both anaesthetists, surgeons and patients to work out what they would like to basically use regional anaesthesia more. And then another project that I've been involved in is investigating wastage of emergency drugs. So these are drugs typically in anaesthetics that are drawn up at the beginning of a list in every theatre, pretty much every day. They're usually drugs that either increase the blood pressure or increase the heart rate if we've not done our anaesthetic well enough and we need to sort that out. And basically, most of us draw some form of emergency drugs up every day. The drug itself has some manufacturing, has some inbuilt CO2 within the manufacturing, but mainly the syringe and the needle actually is probably the bulk of it. And then we draw them up, we put them on the side, and in some cases, up to 9 out of 10 times, we just put them in the bin at the end of the day. And there are alternatives available in terms of pre-filled syringes, so I'm hoping to introduce those within our department and prove it, and again, just a triple bottom line analysis really, to show that I think financially it's probably going to prove to be cost neutral, but there are sort of social and there are social and environmental benefits to doing that. And it's Hrishi's slide next.
Thanks, Max. So yeah, as we said, both anaesthetic trainees working on sustainable anaesthesia for the year. I particularly work at the Children's Hospital with Rebecca and done a bit of audit and analysis into the anaesthetic gases that we're using. As Chantel mentioned earlier on in the talks, one of the hotspots for carbon emissions in theatre is the use of anaesthetic gases. And although we don't use desflurane as much in our theatres, what we do realise is that just the anaesthetic gases that we use can have a significant effect on the CO2 equivalents per case. And this graph that I made from the work that we did shows that just for the average case, the consumption of anaesthetic gases in the anaesthetic rooms and theatres is far more than you'd get from the average car commute today. So that fits in nicely with the with what we're trying to do with educating the rest of the department and encouraging change and practice based on that. Another body of work we're doing is with the James Lind Alliance, as Max mentioned earlier on. So what we're doing is a priority setting partnership with the James Lind Alliance on sustainable perioperative practice. Now, for those of you that don't know what the James Lind Alliance is, it's a non-profit making organisation that aims to bring patients and carers and healthcare providers all together to identify key priorities for research. And the idea being that the people who need the research most can identify what the key targets are, and that a list of the top 10 research priorities is created, and that's taken to healthcare research funders to try and target research to where it's needed most. So that's a process that we're just getting started now. It's called Greener Operations, and the first step is to send out surveys to nationally across many different regions through many different partner organisations to identify what these different bodies would like to find out through research on sustainable perioperative practice. So that little red dot of gather uncertainties is the stage we're about to start now, hopefully. We have a Twitter account, so please follow us for any updates and keep on the lookout for the surveys, because we like as many responses as possible. So based on that, that's one of the future directions we're planning on going. Other steps that I'm taking at the Children's Hospital is to increase usage of intravenous anaesthesia, which is an alternative way of delivering anaesthetics that doesn't use volatile agents. So steps that we're doing is to identify barriers to using this kind of technique and to target them, and developing a guideline for its use in children, which isn't very common. And Max?
And yeah, so as I've said, we're in the process of implementing a new spinal pathway across MFT. Hopefully that's going to increase the amount of spinals that we use, particularly in day case. And also hopefully introduce pre-filled syringes to assess not just on cost, but also on wastage and how much CO2 we're potentially saving through that. And we're handing back to Cliff and Rebecca now.
Thank you, everyone.
Brilliant. So thank you very much, Max and Hrishi. And hopefully what you've all been able to see from Max and Hrishi's presentation is that these are guys who are really running with this agenda and specialising in this, and are going to integrate it in their future careers. And we'd appeal to all of you who work for different specialties. I think that the Health Education England organisations are open to this kind of fellowship. And if you're interested, then maybe think about making it happen. So that brings us to the end of our talk. And I think just by way of a summary, I think it's important just to consider that these things, as Rebecca said, are effortful. And we really thank everybody who wants to make the effort and wants to crack on and make a change. But we don't really know who Dr. Brown is, but this seems like a good quote to finish on, that a leader without followers is just somebody taking a walk. So if you're not that very first innovator, at least try and be the second, and look out for people who are striving in your department to make a positive change, and back them up and go with them, because it's arguably that second person and the subsequent followers who make a real success when it comes to changing behaviour. So thank you ever so much, and we'd like to take any questions.
Thank you, everybody. That was a fantastic presentation. You mentioned that you don't see other anaesthetists practicing. As the surgeon, you don't see other surgeons. So as a surgeon, should I be asking you what inhalational agents you're using? And should you be asking me if I should be using a pre-filled syringe of bupivacaine rather than getting it drawn out of an ampoule?
So I think that's a really interesting idea. And some of you on the call may know that I did a PhD about people's anaesthetic approaches to broken hips. And through doing that, I talked to surgeons about anaesthetist practice as well as to anaesthetists about their own practice. And it struck me that the surgeons have a much better cross-sectional overview of what their anaesthetic colleagues do than anaesthetists do of each other. So I think this collaborative approach is really important. And I think we should, maybe move towards a point where we can politely query the practices of our colleagues if we know that somebody else does it in a different way.
Somebody's asked about, go on, Rebecca.
I was going to say, maybe some of that is knowing the right questions, because as Chantal and, well, most of us have sort of highlighted, it's not always as straightforward as you might think. So maybe the question is, are we doing this with sustainability in mind? And then kind of narrowing it down from there.
Yeah, somebody's asked, what can we do about nitrous oxide in maternity? Are we stuck with that?
I would like
I
to say,
think this is yours.
Sorry, Max, did you want to address that one?
I mean, I would like to say for the time being, yes, probably. It's quite a challenging environment to implement change in maternity. However, there was actually potential, and that is one of the main sources of volatile anaesthetic use within the NHS. However, there was quite an interesting presentation at the Winter Scientific meeting from the Association of Anaesthetists last week, where in Sweden they've been using nitrous capture and destruct technology for the best part of a decade with reasonable success, and I suspect that represents sort of the first step on the way out of it. I mean, ideally, alternative forms of analgesia would be desired. However, I think that will take more time than that.
If I could just come in there as well. Thank you very much, Max. So that's a really good solution for nitrous that's sort of been into the patient and is now being breathed out. But the other thing to think about, which again, some of the Association of Anaesthetists and the Health Education England Wales Sustainability Fellows have drawn to our attention recently, is that there's a lot of nitrous wastage, either from the return and then venting of unused nitrous, or from leaking of nitrous sort of behind the wall, which is not the bit that we as clinicians have a lot to do with. So there is actually, Max and Rishi are the 2019 to 2020 to 2021 fellows, and now we've got some new fellows recruited, and one of their tasks is going to be to look at this world of nitrous oxide behind the Schrader valve, and hopefully in a hospital near you. So if you're interested in participating in that, if I can get a shameless plug in, send me an email, and we're going to try to put together a recipe book for how is it that you go about investigating what goes on behind the wall.
Because as a colorectal surgeon, I was very guilty of starting to use nitrous oxide during endoscopy, which was a recently adopted greenhouse gas that we've used in endoscopy. So that's fantastic. There are a few more questions in the Q&A box, which I think we'll try and do a typewritten answer to. So we're going to take a short break of 5 minutes, and then I'll be back at 16:45 with my presidential address, 2021, A Waste Odyssey, when we'll bring some of these themes together. So a short break, and I'll see you back here in 5 minutes.
President for his presidential address. David was moving straight into a clinical job in surgery, and after passing his primary FRCS, despite being from Liverpool, not Manchester, was offered and accepted a training post here, and says he has never regretted this decision. We're very grateful for that. David completed an MD thesis on research into prognostic factors in colorectal cancer under the supervision of Professor Philip Schofield at the Christie Hospital. Whoops. David has worked in most hospitals in the Northwest and became a lecturer to Professor Sir Miles Irving, a past president of the Manchester Medical Society, where he was given a fantastic and life-changing opportunity of a training post in Paris, working as a chef de clinique at Saint-Antoine Hospital in Paris. On his return to England in 1993, he was appointed as a consultant general and colorectal surgeon in Wythenshawe Hospital, and has also held clinical managerial positions, been the training program director in general surgery, and served as an invited member of the Council of the Royal College of Surgeons in England as its national lead regional director. In 2012, David was invited to lead a Health Education England Better Training, Better Care pilot with the aim of maximising training opportunities, developing dedicated training lists for core surgical trainees, which increased training opportunities and activity. He also developed cadaveric simulation for core surgical trainees in Manchester, in the Manchester Surgical Skills and Simulation Centre when it opened in the university in 2013. This has been delivered to all core surgical trainees in all specialties and has the largest worldwide published experience of cadaveric simulation in surgical training. Another of David's clinical interests, apart from the environmental impact of healthcare, is around the response to major trauma, and was a member of the faculty of the Royal College of Surgeons' flagship Definitive Surgical Skills course, which he helped to bring to Manchester. He was also involved in the response to the Manchester Arena bomb and developed with colleagues a bespoke Manchester major trauma course to train staff from the Northwest involved in trauma management. David hung up his scalpel earlier this year and is now working part-time as one of the new medical examiners in MFT. He is also a joint lead on a James Lind Alliance priority setting partnership on sustainable perioperative care. David.
Hello, well, thank you very much, Josanne, for that very kind invitation. And I'm currently, having worked perfectly all afternoon with Zoom, just experiencing some slight technical abnormalities. So I don't know whether you can see me at the moment because I can't see my shared screen. But if someone could just acknowledge whether you can see me, then I'll proceed with the presentation.
We can
so
see
I don't know. That's fantastic. Well, I'm absolutely delighted that so many of you have been able to join me for this presidential address, because I know that other presidential addresses are currently taking place and are available. And I believe that the USA has already signed up again to the Paris Climate Agreement. So I've called my presidential address 2021 a Waste Odyssey. And I hope you've had an enjoyable afternoon at the Delivering Sustainable Healthcare Symposium. And the main thrust of this theme for my presidential year is that you go away, think about your own area of practice and life, and do something about it. So what is this Waste Odyssey that I'm going to talk about? Well, I've had a career as a consultant general and colorectal surgeon, and I've spent lots of time in the operating theatre managing the human waste system. And as you get older and perhaps wiser, then you start to think of the bigger picture. So I started to look at the waste in theatre, and then with my work around professional affairs became aware of the wasted resources that take place in the NHS. My former colleague, Ed Kiff, who's retired and a former past president of the section of surgery, always has lots of wise advice. And in retirement, he advises that you should retire to something and not from something. So I've not completely given up work. I don't want to waste the skills that I've got. So part-time, I'm working as a medical examiner, and I'm also supporting the James Lind Alliance priority setting partnership around sustainable perioperative care. And my journey to retirement has got me interested in things like the history of medicine in Manchester and the Medical Society, and also astronomy. So perhaps surprisingly, astronomy is where I'm going to start this talk. And I'm very proud of this photograph, which I took of the Ring Nebula from Highley Community Observatory the year before last. It's the light radiation from an exploding red giant with the white dwarf remnants in the middle. And I did get feedback from a retired professor from Jodrell Bank who said, it's not bad. And astronomy gives you the concept of time, and the light traveling to reach my camera left the Ring Nebula over 2,000 years ago. And what was happening 2,000 years ago? Well, Hippocrates, the Greek physician and many view as the father of medicine, was talking about the importance of air, water, and places and the environment in healthcare. And that's as important today, as we've seen, as when Hippocrates was writing about this over 2,000 years ago. Now, this is said to be one of the most important photographs ever taken, and it's the blue dot. The blue dot is planet Earth, which is taken from Voyager 1 when it was 6 billion kilometers away. And if you get involved in astronomy, you inevitably come to something called the Drake equation, which predicts the likelihood of us encountering other life forms in the Milky Way, where n is the number of civilizations that we could communicate with. And the key factor is this one at the end, L. And unfortunately, L is the lifetime of a civilization and how long that civilization remains in communication. We've only been communicating for about 100 years since Marconi first broadcast his radio waves, but estimates of L because of climate change are as low as 300 years. So we do need action after today's talks. And we've heard about climate change, and there's lots of representations of it, and this is just one. And this graph shows the effect of the rising temperature on the y-axis, and it goes back to the mid-1800s and the pre-industrial period. And this rise in greenhouse gases and the rise in temperature dates back to the pre-industrial age. And of course, that brings us home to Manchester, which we've already discussed today, was the cradle of the Industrial Revolution. So as Raja said, I did try to suggest that Manchester was the cause of climate change, but hopefully also the solution. And Manchester in the 19th century was described as this sewer of gold. And it was described as a place where there was a foul drain from which the greatest stream of human industry flowed out to fertilize the whole world. So in effect, where there's muck, there's money. So Manchester has made wealth, it's made lots of problems. And many of you may have been around Manchester and visited the Bee in the City art installation in 2018, which celebrated Manchester's heritage. And Manchester has made lots of advances, contributed lots, but it's also made lots of problems. And also we found the solutions. The muck that's led to the money's been reinvested in science and technology and medicine. So I want to tell you 5 stories related to Manchester, related to the history of medicine and surgery in Manchester, with a climate change theme. The first one's going to be about the development of medicine and surgery in Manchester. Then I'm going to move on to the development of antiseptic surgery and Manchester's role. And then I'm going to move on to a story about a king, Arthur Burgess, a former president of Manchester Medical Society, modern surgery and Professor Sir John Charnley, and end with where the journey's going next for me with the James Lind Alliance Priority Setting Partnership on Sustainable Perioperative Care. So we're going to start with the development of medicine and surgery in Manchester and think about these three characters, Jordan, Turner and Bardsley. So Joseph Jordan opened the first provincial school of anatomy in Manchester on Bridge Street, which is just off Deansgate, in 1814. His rival, Thomas Turner, opened the Pine Street School of Medicine, which is also in the centre of Manchester, in 1824. There was a huge explosion in population. There was a need for medical care, and this was all fueled by industrialisation. Jordan and Turner's schools of medicine eventually merged and evolved into what became Owens College, the University of Manchester, and the medical school as we know it today. Both Jordan and Turner, they were both founder council members of the Manchester Medical Society back in 1834, which was created to foster harmony amongst the medical community. Their success in providing provincial education was recognised. They were founder council members of the Royal College of Surgeons of England when it was created in 1843. Previously, the College of Surgeons had been known as the Royal College of Surgeons of London, but in part due to recognition of the success of provincial education, it became the Royal College of Surgeons of England, and both Joseph Jordan and Thomas Turner were founder members. Now you can actually go and say hello to Joseph Jordan. Many of you have probably passed Joseph Jordan, whose bust last time I was there was in the foyer of the Stopford building in the medical school. And we know quite a lot about Joseph Jordan thanks to one of his students, John Hatton. You're going to hear more about John Hatton later relating to human waste and sanitation in Manchester, but Hatton kept meticulous handwritten notes of Joseph Jordan's lectures in the 1837 to 38 academic year, and it was beautifully illustrated. The main topics were how to distinguish hydrocele from hernias. And the reason for that is because a strangulated hernia, before the days of anaesthesia, was one of the few operations that you could actually perform. I think I might have liked Joseph Jordan. He certainly liked himself. He liked to boast about his ability. And the fact that in the operation for strangulated hernia, you could have great satisfaction because if the operation was successful, you at once snatched the patient from the grave. And he was able to boast that he'd cut between 30 and 40 people for femoral hernia and never lost a single patient, which none of his rivals could claim. This is all the more remarkable because it was before the introduction of anaesthesia. So all of these operations were actually done on an ambulatory basis. They were done on the patient's dining room table or perhaps on the kitchen table. But thinking to the future, and we'll come back to this later, is this drive to save people from the risk of a strangulated hernia, perhaps in due course, led to excessive amounts of hernia surgery. But we can discuss that later. I want to move forward to 1846, and again, the concept of time. And going back to my retirement interest in astronomy, Neptune was discovered in September 1846, just a few weeks before the first operation under ether anesthesia took place at the Massachusetts General Hospital. The Industrial Revolution and industrialization gave us all of these chemicals and substances which doctors in the mid-19th century could experiment with to see if they were any use. And ether was one that was found to be of use as an early anesthetic agent. And why have I mentioned Neptune? Well, Neptune takes 165 years to go around the sun. So it's actually only just completed its first orbit since the time it was discovered. And during that last orbit, the whole all of the modern developments in medicine we now take for granted have taken place. And we've also seen the problem of climate change, all in the last orbit of Neptune. Thomas Turner, who you'll recall was a rival to Joseph Jordan, became a surgeon at the infirmary, and along with his colleague James Bardley, a physician, reported the first public administration of ether anesthesia in Manchester early in 1847. Again, this was ambulatory care, took place in the patient's home. And it's said that Dr. Bardley asked Mr. Turner to commence the operation, which he did with great alacrity, removing the tuber with just a few strokes of his knife. But it took a long time for surgery to catch on under anesthesia, because it was still a very risky business. And so the medical fraternity and surgeons needed to occupy themselves with something else. And going back to John Hatton, who wrote Jordan's lecture notes, he became a surgeon in his own right in Chorlton upon Medlock, just north of the university and south of the city centre. And he was very interested in the problem of human waste brought about by the back-to-back housings, which he drew beautifully. And along with many other medical people, he was a member of the Manchester and Salford Sanitary Association. And he wrote about the River Medlock, which passes under Oxford Road, just north of the university, which he described as one of the biggest nuisances in Manchester. Now, I don't know today, it might be flooded today, given all the rain we've got, but it's usually slow flow and was a place for accumulation of human waste and animal waste and all sorts of detritus. And Hatton referred back to the teachings of Hippocrates and the importance of the environment. And he explained, he observed the gases that were bubbling out of the river, along with the dead dogs and cats that he described as floating there. And these were bubbles of carbureted hydrogen, which would be methane, one of our greenhouse gases. So we've heard about the early development of medicine and surgery in Manchester. And the next little story we're going to talk about is the development of antiseptic surgery. Because although we had some anesthetic agents, most people undergoing surgery or went into hospital were vulnerable to infections. And this is a Manchester hero, Frederick Calvert, who was an industrial chemist, and perhaps somebody you've never heard of, but there's a blue plaque to him on the library, which was the site of the institution. And he was also a member of the Manchester and Salford Sanitation Committee. And as an industrial chemist, he produced all sorts of things. And in particular, he experimented using lime to try and purify the River Medlock before it drained into the Bridgewater Canal. And it was his ability as an industrial chemist to develop these agents. He's perhaps most famous for the production of carbolic acid soap, and Calvert's carbolic acid soap was a bestseller, which was produced at a factory just east of the centre of the town, somewhere near where the Etihad Stadium is now. But carbolic acid underpinned Joseph Lister, who was the pioneer of antiseptic surgery. And when Joseph Lister was working in Glasgow, he was aware of experiments using carbolic acid to try and get rid of the smell from sewage in cesspools from cattle in Carlisle. And he found that the carbolic acid came from Frederick Calvert in Manchester. And carbolic acid is a waste product of the Industrial Revolution, or it was a waste product from the production of coke and gas from coal. And Calvert's carbolic acid was supplied to Joseph Lister and was used by Lister when he pioneered antiseptic surgery. And the University of Manchester Library Archives have several letters from Lister to Calvert, thanking him for the carbolic acid and alerting him to publications that were going to be in the British Medical Journal and Lancet. So we've seen how the Industrial Revolution underpinned the development of modern surgery. And I'm going to fast forward now, because now we know there's a huge amount of activity with an associated carbon footprint related to surgery. And the scale of the problem, and it is a problem, was highlighted just last week by the reports that there are something like 4.5 million people waiting for treatment in January 2021, which was reported by the College of Surgeons because of the problems with COVID-19. And this degree of healthcare is clearly associated, or clearing this healthcare is associated with a huge carbon footprint. So the next story I want to move on to, having looked at the development of antiseptic surgery and the pivotal role that Industrial Manchester played, is the modern surgery. And the story I want to talk about is that related to Professor Sir John Charnley. Professor Sir John Charnley was from Bury. He was a Manchester graduate. He was first a consultant at Park Hospital, which became Trafford General, then Manchester Royal Infirmary, before moving on to Wrightington Hospital, where he developed and pioneered hip replacement surgery. He not only developed the hip replacement surgery, but he was aware of the risks of sepsis and how that could lead to failure of joint surgery. And he was honoured with a very prestigious Lister oration to the Royal College of Surgeons of England in 1976, when he spoke about asepsis in the operating theatre and the clean air systems, which he was pivotal in developing, which have been so crucial to our healthcare today. Of course, this has been highly successful, and there is now a huge volume of surgical activity. We could look at lots of examples, but just looking at hip replacement surgery, these are the latest data from the National Joint Registry that show that there were over 95,000 hip replacements in 2019. It's very difficult as a colorectal surgeon to appreciate the skills of an orthopedic surgeon, but clearly this is surgery that makes a huge difference to people's lives, but it is associated with a significant carbon footprint. And we know, we've heard that 4% of our carbon footprint is related to healthcare emissions. So whilst this is fantastic surgery with fantastic benefit, we have to look at how we can provide this as well as delivering the target of a net zero NHS by 2040. And this is perhaps the most complicated graph that I'm going to show, but it shows our carbon emissions on the y-axis on the left, and it shows two projections. There's an upper projection, which is the do nothing for our carbon footprint, and the projected scope to get to net zero by 2040. You don't need to look at them in detail, but the list on the right-hand side names most of the things that we need to tackle if we're actually going to reduce our carbon footprint. So it's very easy to say what we need to do, but to do something is much more difficult. So whilst we're talking, I want you to be thinking about what you can be doing to reduce the carbon footprint of healthcare. There's an initiative that you may well know about called Get It Right First Time. This has been running for a number of years and again started in orthopedic surgery, but it's all about reducing the variability in healthcare. And when the first Get It Right First Time report came out relating to orthopedic surgery, there was lots of variability in how we treat people for joint replacement surgery. So the Get It Right First Time has fed back to individual hospitals and clinicians, has been a modification in practice, And just last year, they reported how changes in practice had taken place in response to GIRFT between 2014 and 2019. And they calculated that 49,000 procedures had been avoided, with a huge reduction in the associated carbon footprint from hip replacement surgery. So there are things we can do. There are lots of other examples, and I'll just go through a few quickly. The first one relates to inguinal hernias, and that surgical dogma that anybody with a hernia needed surgery in case they developed a strangulated hernia meant that many people had groin hernia surgery, perhaps didn't need it. We don't do patient-reported outcomes on inguinal hernias, but these were the last data that show that only 39% of people responding to our quality of health questionnaire were improved by their surgery, and the majority were either worse or had no change. So it's something we can start to think about, because there may be some unnecessary surgery here that's associated with a significant carbon footprint. And also during the COVID pandemic, the Green Endoscopy Group have looked at the provision of endoscopy and estimate that something like a quarter of all endoscopy procedures may not be absolutely necessary, and that's clearly associated with a significant waste of resources. And going back to my own field of bowel cancer, we have regular bowel cancer audit publications, and the key point is the variation in length of stay. Just looking at the bottom line on the right, those patients stay in less than 5 days vary between 28 and 49%, depending on where you were treated. And because of the huge volume of patients that undergo bowel cancer surgery, this difference in length of stay is associated with a very large carbon footprint. And my own pet hate is finger switch diathermy. And this again is a theatre tray, and we've talked about reusable and single-use items. And diathermy is used to coagulate blood vessels. There's a perfectly usable diathermy that comes on the tray used for inguinal hernias, but everybody likes using these finger switch diathermies. They're very nice to use, and they're very cheap, only £1.64. When I started looking as if I could remove these single-use items, the cost was not viewed as significant, but there's clearly metal and plastic and the production costs. I had hoped to stop the single-use item being opened as well as the reusable item, but I failed miserably. But if any theatre people are looking there, do you really need to use finger switch diathermy for every case where you've already got a perfectly adequate reusable item? So we've looked at the development of modern surgery and its carbon footprint, and started to think about some of the things we can do to start changing the carbon footprint that's associated with healthcare. And I now want to move on to the story of a king, a former president of Manchester Medical Society, and appendicitis. And I think I did launch the next Slido question, and the number again is 2653. And if you have a non-perforated appendicitis on a CT scan with mild symptoms, what's your preferred treatment? Would you want an appendicectomy? Would you want antibiotics? Or you're not sure? So if you want to answer that on Slido, I'll come back to it later. And if we think again about Jordan's lecture notes written by Hatton, there was no mention whatsoever of appendicitis because it wasn't actually described as a condition until 1886. And even then, although people were advocating surgery for appendicitis, it didn't actually become popular until the early 20th century because of the risks associated with surgery. That all changed with Edward VII, and you may or may not know that Edward VII's coronation was delayed because he developed acute appendicitis. He was advised to have surgery, but was very wary of this because it was still very risky. But he eventually did succumb to surgery, which was performed by Sir Frederick Treves, who was supported in the operation by Joseph Lister himself, who by that time was working in London. And of course, following the tradition we've heard of, this was of course ambulatory surgery, and the operation took place in the patient's home, Buckingham Palace. It was a huge success, and he made a recovery and went on to have his coronation, although it was deferred. And I found since I've become president that appendicitis has been discussed at Manchester Medical Society on previous occasions. And you can see how the dogma around appendicitis have developed. This was back in 1907 when the then president, Dr. Moritz, held a meeting that was hosted by two previous presidents of Manchester Medical Society on acute appendicitis. And the change was happening. As soon as the diagnosis is made, it's time to call a surgeon. The onus of proof is on him who advises against operation rather than the reverse, and that the sooner they operate, the better the outcome. Now, Arthur Burgess, who was a surgeon at Manchester Royal Infirmary, went on to become a president of Manchester Medical Society, wrote about the understanding of appendicitis in Manchester in the BMJ in 1907. And he was strongly advocating surgery to the point where he advocated that even if you operated in the early stages, you might operate on some people who might have got better without surgery, and raised the rhetorical question, but what harm could possibly come from having a negative appendicectomy? And he introduced the concept that was then emerging, which we're familiar with, of defensive medicine, that if someone actually had an adverse outcome because of appendicitis, then it would be very difficult to justify. Now, Arthur Burgess was the president of Manchester Medical Society back in 1925 to 1926, and his presidential address was given on the 3rd of February 1926, and it was actually published in the BMJ 3 days later. I'm very disappointed that no one's approached me to publish this in the BMJ, but he gave a very good description of the explosion in surgery that happened in the first quarter of the 20th century, when there was a 15-fold increase shown in the red box in surgery in Manchester Royal Infirmary for acute abdominal conditions, and the mortality dropped from 36% to 8%. And his main area of practice related to appendicitis. Appendicitis, there was a 50-fold increase in the number of people undergoing surgery to have their appendix removed at Manchester Royal Infirmary from 1900 to 1924. And there was a fantastic reduction in mortality from 64% to 5%. So surgery was becoming the norm for appendicitis. And in his presidential address, he advocated that all cases should be submitted to operation as soon as it can be satisfactorily arranged. And that was the only way that you could achieve the object of the greatest good to the greatest number of people. Now, if we fast forward, I actually wrote about appendicitis myself in the BMJ in 1992. And at that stage, I had no knowledge whatsoever of Arthur Burgess or his previous publications in the BMJ. When I was a trainee, anybody with a hint of appendicitis or the slightest bit of pain in the right iliac fossa had to have their appendix removed. And as an on-call registrar, it was very much frowned upon if there was somebody on the ward in the morning with possible appendicitis who hadn't had their appendix moved. So I reinforced in that article the importance of performing an appendicectomy as soon as the patient's clinical condition permitted. Although I did raise some doubts or some caution that people with equivocal symptoms could undergo a policy of active observation. And then if we move forwards to current times, one of the successes in surgery has been the research collaboratives amongst trainees in surgery. And they highlighted in 2018 the problem of negative appendicectomy rates. There were something like 43,000 admissions a year from appendicitis. And this is, of course, associated with a significant carbon footprint. And it was reported just the year before last that almost 30% of females undergoing appendicectomy had a normal appendix and perhaps didn't need their appendix removing. And this was actually covered in the media, in The Guardian, about the unnecessary surgery. They didn't talk about the carbon footprint of the surgery, but that would be evident. And of course, practice this year or last year has changed because of the coronavirus pandemic. The risks of coming into hospital changed. The risk to theatre staff and the operating teams changed. The need to wear different PPE, and practice changed. And there was awareness that perhaps people might get better without surgery for appendicitis. And there has been some changes observed. And these are some data that came out earlier this year from another research collaborative called COVID Harem, which relates to studying people who've had appendicitis, which has either resolved or recurred, been seen as emergency, and the associated morbidity and mortality. Now, in the first wave of the coronavirus pandemic, they reported on 500 patients across 50 sites, of whom over half were treated conservatively, the vast majority with antibiotics. And in the study period, only 26 had progressed to surgery. And there was a large randomized controlled trial published in the New England Journal of Medicine just before Christmas in November, comparing antibiotics for appendectomy, as it's called in the USA, for people, certain groups with appendicitis. And there was an associated editorial. And the bottom line, the graph shows the cumulative incidence of appendectomy in those managed conservatively. And overall, approximately 2/3 of patients didn't need to undergo an appendectomy, and antibiotics were viewed as non-inferior to appendectomy. So clearly, some people with appendicitis could be treated without surgery, and that would be associated with less waste of resources and lowering our carbon footprint. But clearly, we need to think a little bit beyond the box or beyond the circle. So we've looked at how perhaps all cases of appendicitis do not need an operation, and perhaps there's potential for some saving otherwise wasted resources. One of the biggest regrets in my own personal odyssey as a surgeon is that I wasn't involved as much as perhaps I could have been in clinical trials. And clearly there are lots of unanswered questions, such as those related to appendicitis. And that brings me on to the work with the James Lind Alliance Priority Setting Partnership around sustainable perioperative care. And James Lind was a Scottish naval physician, And he was very much aware of the waste of sailors' lives. And this was exemplified by George Anson's voyages around the world with a flotilla of boats, which took 4 years. And he set off with a total of 1,900 crew, 1,400 of whom lost their lives due to scurvy. So their lives were wasted due to scurvy. And James Lind did an early trial. He compared a number of different agents to see if he could solve scurvy. Some of them were quite obnoxious, such as seawater, horseradish, vinegar. But the one that he found successful was citrus fruits. And citrus fruits were introduced into the Navy and was a solution to scurvy, which saved a lot of lives from being wasted. And the James Lind Alliance, his name is applied to the James Lind Alliance, which is allied to the National Institute for Health Research, which runs priority setting partnerships. And these, as we've heard earlier on from Rishi, raise awareness of research questions which have direct relevance and potential benefit to patients, carers and clinicians. And it's about addressing uncertainties about the effects of a treatment, which should become accepted as a routine part of clinical practice. So we should be asking more questions. And the key thing about the James Lind Alliance, PSP, that it involves patients, carers and clinicians working together to agree which amongst those uncertainties matter most and deserve most priority attention for research funding. So the Greener Surgery, as we like to call it, Sustainable Perioperative Practice Priority Setting Partnership, is hosted in MFT Charity, thanks to we're very grateful to a philanthropic patient who donated the funds that we use in MFT Charity. It's led by Cliff Shelton, who you've heard from earlier on, and myself. And we had hoped to bring you more news of this in today's symposium, but the PSP has been delayed because of COVID. But we're looking to address the top 10 priority questions for research funders related to sustainable healthcare that can be delivered and reduce our carbon footprint. As you've heard, we're going to use surveys to determine these priorities. And we have just held the first meeting of the steering group, and hopefully we'll be able to bring you news in the future of the priorities, which we hope to put forward relating to delivering sustainable healthcare with good outcomes. The Greener Surgery, PSP, we've got fantastic partners, and these are just a few. There are many more coming on board, but it's a project of national importance with partners such as the Royal Colleges, Centre for Perioperative Care, Association of Anaesthetists. So watch this space and follow us on Twitter. So that's my waste odyssey, starting from my life as a surgeon managing human waste to thinking about the bigger issues of waste in general in surgery and the waste of healthcare resources, and my journey where I'm going now. And so the question I would put to you is, what is going to be what are you going to do in your area of life or practice relating to your hospital, healthcare, your private life? I'll put some of my own examples on, such as, do we really need to sit under patio heaters, even if there is a fantastic view of the Shard? Thinking about things we can do in our personal life, thinking about things at work, such as our waste, the use of our surgical kit, whether we really need to go abroad for international conferences. And are you going to go any further? Obviously, there lots of interest in this area. And are you going to go and speak to government? Are you going to go and protest? So that brings me to the end of my talk. I'll need to just log out of the talk to activate the next Slido question, which will again use in 2653. I'm going to leave that open so that you can continue to use it after the talk. And I we're very happy to take any questions, and I will just need to get Slido back up. So I'm happy for any other members of the panelists to come on board whilst I just try and get back my Slido and launch the question.
Thank you very much, David. That was a very interesting talk, and certainly made us all, I'm sure, think a lot about what we might be able to do. We have I have one question.
So I've launched the Slido poll.
Yeah. There's one question in the Q&A. Would the Christabel Pankhurst Institute be involved in the Sustainable Partnership?
I don't know them particularly. We've got a lot of partners, and the way the partners work, we're looking partners who can help us get access to the patients, the carers, and the people to whom we need to submit the surveys. So if you follow us on the Twitter account and direct message us with your details, we will get in touch with you. We're currently designing the questions for the PSP, and we'll be looking to circulate the surveys widely. I've lost vision of the Zoom screen myself, so I can't look at the Q&A box myself at the moment. So if one of the other panelists could do that, that would be very useful.
There isn't another question, but can I ask a question? We were talking about earlier about or somebody was talking about the hierarchy of in terms of sustainability, with sort of prevention being at the top. How will your initiative or will your initiative be working with the medical students who are going to be the doctors of tomorrow, and who are going to be the ones who we might have the most impact on in terms of changing practice?
Well, we want to engage. The key thing is to engage with patients and carers as well as clinicians. But yes, we want to engage with undergraduates. I'm planning, which we've not advertised yet, a follow-up event to this, because Manchester Medical Society likes to support some undergraduate activities. And I'm hoping if Kevin Anderson from the Tyndall Centre for Climate Change can join us in the future, to include him in that meeting. But I think it's most important that we engage with undergraduates. And as you've heard, my colleague Cliff Shelton has already, and Rebecca Sutton, very actively involved in delivering the sustainability agenda to undergraduates. So yes, it's very important.
Thank you. I don't think there are any more questions. So I just like to say thank you for a really, really interesting afternoon. All the lectures were very thought-provoking, and hopefully make us think a little bit and do our own little bit to improve sustainability.
So what I would say, I can't see the answers to the poll at the moment, but I'm going to leave it open. So please do submit your answers, and then we'll look at putting that on the website of the Manchester Medical Society. So before we just close, I'd like to say a huge thank you to all the speakers who've contributed to today's symposium. I'd like to say a huge thanks to the staff from Manchester Medical Society, Fiona, Sarah and Janet, who've done so much hard work to get the society up and running again after the first lockdown. And we're now running quite a big program of online events, and we're very grateful for all the hard work they're doing. And if you're not already a member of Manchester Medical Society, then please do consider joining. So if there are no more questions, we will end it there, and I'll return back to Fiona, but please do message us or email us or use the Sustainable Op Twitter account. Thank you very much and stay safe.